Ravi, Dr. Abdul, Dr. Shefali, Dr. in White, Meet Patel, and I think we can get started with questions just to get the rhythm back. It's been a long time. I think that I've not had a session with you guys. Very good evening, Dr. Bhargav, Animesh, AK47, welcome back. Soni, Monica, Akash, Sushant, Dr. Harish, Dr. Vijay Meena. So, sorry if I missed out a couple of names there. And let's focus at the job at hand, which would be that my objective of today's session is just to the skills of MCQ solving tend to get rusted if you do not do questions for a few days, as you guys are very well aware of. So let's just practice a couple of questions together, and let's see how can we stop avoiding making silly mistakes. Okay, fine. I'm having inputs there also. Yes, very good, very good. Nice to see you, Dr. Ramu. Okay, Avinash, don't worry. I'm waiting for answers, guys. We have this 30-year-old patient, bilateral leg weakness and paresthesias in the feet. There's a distal areflexia in the patient with extensor plantars. So the movement, like you were having two things in this question. One is features a lower motor neuron lesion. Why I'm saying lower motor neuron lesion would be one because of the weakness component, which is not specified whether it is spastic or is it flaccid, but because it's saying distal areflexia, so I am considering that that would be a feature of lower motor neuron. And then simultaneously, what you're also noticing is extensor plantars in the patient, which means that corticospinal pathway is getting involved in the patient. So whenever we study about, no, Dr. Modi, this is not a Guillain-Barré syndrome. I think most of the guys are getting it very correct. The movement you have is a combination of lower motor and upper motor neuron findings. Then one of the important diseases to be considered is vitamin B12 deficiency, that is subacute combined demyelination of spinal cord. And if they give you a very long history of a asymmetrical weakness, then another disorder which is to be considered is amyotrophic lateral sclerosis. Now in this question, he has mentioned bilateral involvement. Usually in amyotrophic lateral sclerosis, we might be having is only one leg weakness and a contralateral arm weakness. It could be like the same leg or the same arm, but the bottom line is we usually do not get a bilaterally symmetrical involvement in amyotrophic lateral sclerosis. It's mostly gonna be a asymmetrical profile spanning over large number of years. So we need to first consider our possibility of subacute combined demyelination, and therefore answer looks like B. But let's look at okay, somebody put up multiple sclerosis there also, because possibility of even in multiple sclerosis you can also be having a spinal cord involvement that can cause transverse myelitis in a patient. So at the level of the lesion, lower motor neuron lesion, and above the level of the lesion, it would be an upper motor neuron lesion. So yes, one of the important diseases, another very good input that came up from one of the doctors was, can't it be multiple sclerosis in an individual which is causing transverse myelitis, that is longitudinally extensive transverse myelitis. So at the level of the lesion, lower motor, and below that upper motor neuron manifestations would be present. But on a comparative scale, I can say, yeah, Friedreich ataxia is one of the inputs which we need to consider. But if I look up at these disorders, then the first thing that I need to do, because it's saying what should you be doing next in the patient, the first thing I need to do is rule out vitamin B12 deficiency, because that would be a disease that is relatively more common. So I agree to the fact, option number A, I think everybody could rule out, that is lumbar puncture and nerve conduction velocity, because this would help you in identifying Guillain-Barré syndrome, but this is not a GBS, because GBS does not have a upper motor neuron presentation of extensor plantar. So A is ruled out. And you never start something like intravenous immunoglobulins on an empirical basis. So I'm left with two possibilities. Either it's gonna be serum vitamin B12 and nerve conduction velocity, because you could be having a peripheral neuropathy with a corticospinal tract demyelination occurring in a patient, or it could be transverse myelitis in the patient. On the basis of, I would say, prevalence perspective, B looks like a more common answer. We need to give more common things first. And another reason why I am negating the possibility of transverse myelitis is because when you have a transverse myelitis occurring in an individual, most of the time we also get bladder and bowel involvement, which somebody pointed out very, very rightly. Yeah, Avinash put that out, bladder and bowel involvement, which is not given in this question. So there are two reasons why I'm giving I would say SCD, a preference over multiple sclerosis in this question. One would be the one disease that is the first one is more common, and second is the classical profile of transverse myelitis is, and longitudinally extensive transverse myelitis is not given in this question. So the correct answer for this one would be a good starting from everybody. Good evening, Lalit. Good evening, Kishore Kumar. The correct answer for the first question for today is option number beta, and our objective would be to solve as many questions as possible. I have started with relatively easier ones just to get the rhythm, and then subsequently in my future sessions we'll incorporate a little more technically demanding ones as well. Starting with the second question for today. Very good evening, Dr. Akhtar. We have this marathon runner who's having muscle cramps and collapses before the finish line. So I'm thinking it could be either a possibility of electrolyte imbalance, either it could be hypokalemia, or it could be a hyponatremia in a person, or a combination of the two, which could have resulted in this kind of a yes, Avinash, we will have sessions. And because muscle cramps are something that are associated with electrolyte imbalance, so the moment I read this question, I know that okay, man, I'm reading with the question deals with the electrolyte imbalance. Now he's rushed in an ambulance to a hospital, pulse rate is increased anyway. I mean, because the logic behind tachycardia would be that he would have sweated a lot during marathon running, so dehydration component coming up. BP is on the lower side. Good evening, Santosh. I'm getting A as an answer. Check it out, guys. I mean, read the question carefully. Vitals of the patient are showing evidence of dehydration. Is normothermic to touch at the movement with dry oral mucosa and lips. That again, I mean, gives credibility to the diagnosis of dehydration in the patient. And the blood work shows a sodium of 130. Now, if you're having a sodium of 130, potassium of 3.5 on the lower side, so yeah, electrolyte imbalances are present in a patient. He says, which of the following is best for the management of this patient? Thank you, Dr. Amin. If I start with A, 3% hypertonic saline, we give 3% hypertonic saline mostly in dangerous hyponatremia. So usually when sodium values are less than 125 milliequivalents, that is when, or there is a concomitant seizures in a patient, that is when we have to give hypertonic saline to a patient. Because giving hypertonic saline again is something which is fraudulent with risks. Because when you give 3% saline fast, you know the disaster that can occur. The disaster that can occur is osmotic demyelination syndrome. So one reason why A is not the answer to this question is primarily because hypertonic saline would be indicated in dangerous hyponatremia. Second, if you give it fast, it can cause osmotic demyelination syndrome. So considering a sodium of 130, I'll be more comfortable giving normal saline to this individual. And I can rule out option number B, which is N/2 and 5% dextrose. That would be used when there is a hypernatremia. And ringer lactate anyway can be ruled out because that you use when a person is having either a presentation of diarrhea or is having a presentation of burns. So yes, loss of fluid because of running in a marathon runner, hyponatremia is one of the reasons why this patient is presented to us. So we'll be using normal saline for management of this chap. Considering a sodium value of 130, you can understand that there would be no urgency for you to start with hypertonic saline in the patient. So the answer to this question is option number C. I think A and B were relatively simpler ones and have had good inputs here. Sir, per day rise would be 8 milliequivalent, and overall rise in the patient we should achieve like something like about 140. In the same patient, potassium of 2.5, which fluid would be, sir, we first need to correct the hyponatremia component in a patient, so we'll still give normal saline to the patient. And since potassium you're saying 2.5, which is dangerous, I would add KCl. You know, the potassium in ringer lactate would be 2 less. Like, you know, suppose Avinash says that in this question potassium was 2.5, would you still give normal saline? I am saying yeah, I would give normal saline, and I will add KCl. I'll add ampule of KCl to the normal saline, because the potassium which is present, it's not about first potassium, it's not about first sodium. It is the fact that ringer lactate में जो potassium का value होगा, that is gonna be too less to take care of a dangerous hypokalemia kind of a situation, because once values go in 2.5 or lesser, it becomes dicey and you get pretty severe muscle weakness and diaphragmatic weakness and prostration in a patient. So I would add potassium chloride ampule based on the formula which I've taught in the routine videos, and I'll add KCl to normal saline for the patient. So both would be corrected simultaneously. It would be normal saline plus KCl. Hi Vikram. Sir, KCl ka correction. Okay, now since you put up that question, so I'll just mention that आई थिंक वी हैव डिस्कस दैट कि मतलब पोटेशियम का करेक्शन कैसे देते हैं. तो अगर आपको 1 मिली इक्विवेलेंट का राइज चाहिए ब्लड में, if you read 1 milliequivalent का rise, like suppose the value is 2 milliequivalents and you want to rise to 3, so you need to give 200 milliequivalents of potassium chloride, 200 milliequivalents of KCl to be given to the patient, which is to be added to the IV fluid of the patient. Like for example, the scenario which Avinash created for me was 2.5, तो मैं 2.5 से 3.5 नहीं लेके जाऊंगा. I would like to increase it from 2.5 to 3 milliequivalents only, क्योंकि 3 से जो 3.5 का हाइक होता है वो हम ओरल करेक्शन कर लेते हैं. वंस दिस मैराथन रनर विल बिकम बेटर बाय इलेक्ट्रोलाइट रिप्लेनिशमेंट, तो हम यहाँ पर ओरल पॉट क्लोर ऐड कर सकते हैं और 3 से 3.5 का इंक्रीमेंट ले सकते हैं. तो जो हाइपोथेटिकल क्वेश्चन जो डिस्कशन में क्रिएट किया गया कि पेशेंट का वैल्यू 2.5 होगा, आप कितना पोटेशियम क्लोराइड देंगे, तो मुझे जो हाइक चाहिए वो सिर्फ 0.5 मिली इक्विवेलेंट का ब्लड में चाहिए. तो मैंने आपको मैथमेटिक्स में भी बताया ही था कि 1 मिली इक्विवेलेंट राइज वुड रिक्वायर 200 मिली इक्विवेलेंट्स. So 0.5 milliequivalent would be requiring half of this, that is 100 milliequivalents of potassium chloride would be added to normal saline, whatever you have to give for the dehydration component of the patient. And then subsequently, once the values go up to 3 over the next 6 to 8 hours or maybe 12 hours, once he's better, then you can start oral pot chlor. And instead of pot chlor, I mean, you can give coconut water, banana. I mean, once you start taking orally, and the patient would recover. The correct answer for the question that I created before you was for hyponatremia, and we'll be using normal saline in this case because we're not having a dangerous hyponatremia situation. Okay, guys, good, Avinash. You did good input, or provided a good input there. Moving to the next one, we have this individual sudden onset headache with vomiting. The moment you read about headache and then you read about vomiting in a person, you start thinking in terms of raised ICP, and moreover he is also saying double vision in an individual. That gives even, that increases the fear in our mind that okay man, there could be a raised ICP occurring in an individual. Now thankfully in this case the Glasgow Coma Scale is still 15 on 15, but there's a nuchal rigidity. So yeah, you know that every time we read about headache and then vomiting, features of raised ICT and nuchal rigidity in a patient, we have to consider subrectal hemorrhage in an individual. I repeat the fact once again, the combination of headache and nuchal rigidity in the patient, I'm thinking in terms of subrectal hemorrhage, and then I'm going to have a look at the eyes of this individual. When I have a look at the eyes of this individual, you will notice that one of the eye is looking laterally, which means lateral rectus function is unopposed. The medial movement is via medial rectus, that's the oculomotor nerve, and the lateral rectus is the sixth nerve, and you can see that the eye is looking down and out. It's looking down and out. So that means that the third nerve of the patient is not functioning. And the moment I read the fact that the third nerve of the patient is hampered, I know my answer, because subarachnoid hemorrhage usually can occur either due to trauma or there could be a berry aneurysm which could have ruptured in this particular case, contributing to problem. And the moment I see berry aneurysm, I mean, everybody would have read that berry aneurysm, ruptured or unruptured, third nerve is the one that is usually involved. And that is the reason why in this particular chap, because the third nerve is paralyzed, the sixth nerve activity is over, I would say unopposed. The eye is looking laterally, it's looking out and down, and anatomically speaking, oculomotor nerve goes adjacent to the posterior communicating artery. I think most of the guys got this right, though I had a couple of chaps who are even mentioning anterior communicating. Guys, the most common site for berry aneurysm is anterior communicating artery. वो तो ठीक है, लेकिन अगर आप मेन डिस्कशन सुनोगे या अनाटमी के परस्पेक्टिव से पढ़ोगे, तो जो posterior communicating artery होती है, that runs adjacent to the oculomotor nerve. तो जैसे जैसे एन्यूरिज्म का साइज इंक्रीज होगा, फिर वो बर्स्ट कर जाएगा, तो वो थर्ड नर्व को कंप्रेस कर देगा. द करेक्ट आंसर फॉर दिस वन इज ऑप्शन नंबर बीटा. इट वाज एक्चुअली अ PYQ, थोड़ा सा मॉडिफाई कर दिया कि इमेज वगैरह डाल दिया इसमें, अदरवाइज द डेटा इज प्रीटी स्ट्रेट फॉरवर्ड. The number one location for subarachnoid, I mean, number one location for berry is okay, anterior communicating artery, no issues with that. But then when it comes to oculomotor nerve involvement, then you need to consider posterior communicating artery in the patient. Lenticulostriate artery is a branch of the middle cerebral artery. If lenticulostriate artery is involved in a person, you usually either get is a pure motor stroke, or instead of pure motor, you could be having is a pure sensory stroke in a patient. So whenever we read about especially lacunar infarcts, or whenever we read about internal capsule involvement of subcortical infarcts, that's when we talk about lenticulostriate artery. Posterior cerebral artery, well, why it is not the answer to this question? Because posterior cerebral artery will also have a oculomotor nerve involvement. Remember Weber syndrome. But then, along with third nerve palsy in posterior cerebral artery involvement in Weber syndrome, you also have is a crossed manifestation of contralateral hemiplegia, and that kind of a presentation is not given in the question. Okay, Dr. Roy says that if no image was given and the question says, where is the likely site of pathology? Agreed, doctor. Agreed. Then you can answer anterior communicating. But considering that there is a definitive lesion present in this patient, there is an unopposed activity of the sixth, the eye is moving laterally. So, yep, I mean, the image does make a matter in this particular case. Lenticulostriate artery is most commonly involved in ischemia. Doc, it can be, I mean, usually it is involved with respect to brain hemorrhage, but then we can't predict which blood vessel stroke will occur. I mean, it's usually MCA, M1, M2 segments that usually get involved. They said site of pathology. Site of pathology. Yeah, likely site of pathology. Absolutely, absolutely. I mean, that word is to be considered. Monica, you have a point there. I mean, because he's saying comment on where is the likely site of pathology, considering that the third nerve is involved in an individual, the image that I've shown you, the answer would be posterior communicating. Varun, I did not get your question. You asked about blunt trauma. So, yep, I mean, blunt trauma can also contribute to subarachnoid hemorrhage or can contribute to, I mean, multiple other intraparenchymal hemorrhage, intraventricular hemorrhage. So, I mean, for this particular question, we need to consider Berry as a primary involvement. Okay, so we started with question number 3. You just had to look at the image, pick up raise ICP, pick up subarachnoid hemorrhage. It was two-step question. First pick up subarachnoid hemorrhage, then pick up the neurological deficit and comment on the location. We started with the third one. Let's move to the fourth one. Elderly gentleman collapses at the Delhi metro gate. You are the doctor you are the first responder on the scene, and what is the first step that you shall be performing? I would like to wait for inputs from you guys. Nimodipine. Okay, Dr. Roy, while I'm waiting for answer for fourth, let me answer Dr. Roy. See, Dr. Roy, what happens is that in subarachnoid hemorrhage, there is a bleed. वो छोटा सा bleed है, right? It's a very small bleed, but the surrounding area, the blood vessels will undergo a spasm. Why death occurs in subarachnoid hemorrhage is not because of the bleed, because the amount of bleed will be very less. The major reason for death in subarachnoid hemorrhage is the spasm of the surrounding blood vessel. I need to neutralize that spasm. And to neutralize that spasm, I'll be using nimodipine in the patient. So it's not to treat the bleed. वो तो थोड़ा सा है. It is the surrounding area जिसको prevent करना है. So I am getting lot of inputs here. A, B, change हो रहा है. Anybody else would like to? Carotid, chest compression, everything coming up here. So guys, I mean, this is something that I never ever want you guys to ever go wrong. And okay, so let's look at the protocol, and because this is asked word to word, so I want you to remember this in the following fashion, and none of these steps should ever, I mean, you have to get it correct, guys, because this is gonna be not the kind of a question which you can afford to get wrong, primarily because your rival will get it right. So normally I teach it in a traditional fashion, but at the moment, because we're doing a quick revision, so I'll put up a quick mnemonic: SRS, AER, AED. I'll tell you what I mean here, and then is the following aspects. Okay, let's look at it. Nobody had issues with scene safety. I mean, that is fine, and that was not present in the options as well. Then you would pat on the shoulders of the patient and check SRS. So you would check for responsiveness. Sir, can you hear me? Can you open your eyes? Can you hold my hand and squeeze your hand? Squeeze my hand. Then is gonna be shout for help. I mean, shout for help or call for help. That would mean that anybody who's done a BLS training can assist you. Then please remember, because in the exam they follow the American protocol. So then is activate emergency response. That is, in US they'll be calling up 911, or like there are apps available which would send the geolocation of that person and yours to the control room so that they can send up help for that area. Then send somebody for AED procurement. Then look for breathing. You will put your hand close to the nostrils of the patient, look at the chest movements of the patient. So the next aspect that you're supposed to do is look for the breathing of the patient, and then look for the pulse of the patient. So it would be, I mean, from the circulation perspective, what you're gonna do is check out the pulse. And on the basis of this input that I have just provided to you here, the correct answer for this one is not AED, sir. It is not AED. It's see, read the question carefully again. Check for breathing efforts. I'm giving you a second opportunity to solve this question. You are the first responder. What are you gonna do in this particular case? If you're still answering C, apply AED and do a rhythm check. I said procure AED. AED has not come at the moment. These are the steps which are to be understood by you. I'll just show you SRS, AER, AED once again. I repeat my statements once again. SRS, AED, and then AER, AED. That is scene safety, responsiveness, shout for help, get activator response 911, AED procurement. I mean, in India, 911 does not make sense, but in the exam, because they go by the protocol. So it all the way more important that you get the data right. It would be you will look for breathing. You're supposed to spend about 10 seconds odd to check out whether the person is breathing or not and check for the circulation part. The correct answer, AK-47. We I mean, I have said this multiple times and I'll say it. There are a lot of videos viral on YouTube. You can search on social media where like a CISF constable at Delhi airport is deploying a AED and saving somebody's life. So you will also get those funny videos of a IAS officer giving CPR to a guy on a chair, and the guy is fine. He's not requiring CPR, but you'll also find where, I mean, a person who has taken AED related training and he's saving a life. So not able to contact me, sir. You can drop me a mail at marwahmedicine@gmail.com. Question number 4, guys, I'll say that would be a silly mistake in case you got it wrong, because all of you read it multiple times. You need to check for breathing efforts, check for carotid pulse. If both of them are absent, that is when you go for chest compression in the patient. So one option that I think everybody could have ruled out right away is the chest compressions are not to be started anyway. First, you need to evaluate. Okay, noise. Okay. Testing. Okay, should work. Okay. So what I was saying was that per se, you don't start with chest compressions right away. You need to evaluate whether there is a requirement of chest compressions in the individual or not, and therefore you have to select between A, B, C. Now, why it is not C is because you don't straight away, I mean, you would not get a AAD right away, no? You need to first procure it. So, okay. Manish, where in MCI maybe the question came. Anyway, the correct answer for question number 4 is option number A. And this that I've explained, SRS, AER, AED, breathing, looking, and circulation for pulse. I mean, just get this deployed in your brain on a permanent basis so that questions like these do not go, yeah, doc. I mean, that's what happens in the exam. Options will always be closed ones, and we know the answer. I mean, this is the kind of a question where we know the answer, and still when it goes wrong, you tend to feel, oh man, why did I lose this valuable mark? So I mean, we need to minimize that. There are two reasons why I mean the scores don't increase. One is lack of knowledge, and second is lack of application. Lack of knowledge is something that cannot be sorted because medical field is so vast. There are so many topics that you might have read everything from all the apps available and all the textbooks available, and still not be able to answer a particular question because you've not read that topic very well. Something, a rare topic might be asked. But at the same time, I mean, those close options ones are the usual source of error. So I'm not criticizing you. If you got it correct, great. But if you got it wrong, you just need to fine tune your reflexes so that you can get answers right. So this इसको सर इसका image जो है, I mean, आपके brain में imprinted होना चाहिए. That's the message. Coming to the next question. Thank you, Dr. Manzoor. Okay, doctor, thank you. Love from Odisha. Thank you, doc. Breathing and yes, that's the point, Dr. Bhargav. Breathing and pulse together, right? So it is breathing first and then pulse written, no? तो भाई आप ऐसे सोचो, मतलब मैं देखो अगर ऐसे सिचुएशन में फंस जाओगे तो क्या करोगे? तो मतलब टुगेदर तो करना है, मैंने बोला 10 सेकेंड्स करना है, बट अगर आप खुद सोचो कि आप किसी को सीपीआर दे रहे हो तो यू लुक एट द पेशेंट और आप देखोगे ना यार इसका सांस चल रहा है या नहीं चल रहा, साथ में उसका पल्स भी चेक करोगे, तो जहां पे वो दोनों चीज आते हैं तो यू लुक एंड यू फील, ऐसे ही बोलते हैं ना भाई, आई मीन एज अ डॉक्टर व्हेन यू गो टू द बेड साइड तो क्या करते हो, यू लुक एंड देन यू फील, तो पहले लुक एट द रेस्पिरेटरी एफर्ट एंड देन फील द पल्स ऑफ द पेशेंट, सो आई मीन दैट इज हाउ वी शुड बी एबल टू सॉल्व इट। ओके जी, एफएमजी क्वेश्चन जो लोग बोल रहे हैं, क्वेश्चन मैंने ट्विस्ट मार दिया है और इसकी वजह से अब लोग फिर गलत कर रहे हैं। 40-year-old man with a 15-year-old history of smoking 20 cigarettes per day, chest x-ray shows a 2 centimeter mass near the mediastinum। अगर mediastinal mass है तो मतलब सेंट्रल कैंसर हो गया। इफ यू आर टॉकिंग अबाउट अ सेंट्रल कैंसर, इसमें अगर मैं क्वेश्चन में लिखता ना 2 centimeter mass near the pleura, suppose in this multicolor MCQ it was written 2 centimeter mass near the pleura of the patient, that would mean that that would be a peripheral lung cancer, and peripheral lung cancer, as I've explained, cannot be approached by doing I mean peripheral lung cancer के लिए bronchoscope नहीं पहुंचेगा, तो आपको CT guided biopsy करना होगा। But because he's saying mediastinum in this case, because this is a central lung cancer, so you can easily approach a central lung mass by doing a bronchoscopic guided biopsy. The correct answer for this particular question is option number A. What I have done in this question is slightly twisted the modified the options, and the main concept is every time you get a lung mass, you are to check out its position. Anyway, first you need to do a CT so that you can check out whether it is, what is the size of the mass, whether it is encroaching on adjacent substances or not. The point is, if it's a central lung mass near the mediastinum, it will compress on the superior vena cava, press on the recurrent laryngeal nerve or adjoining structures. So that is where your answer would be given. Okay, this would not be a CT guided biopsy, guys. That is what I'm trying to teach you. Because the mass is central, so for a central lung mass, you have to go in for a bronchoscopy with a biopsy. I repeat the facts once again. I got carried away with the chat in between. It is bronchoscopy with biopsy. The bottom line is, if it's a peripheral lung cancer, तो bronchoscope वहां तक पहुंचेगा ही नहीं ना सर, तो आपको सीटी गाइडेड बायोप्सी करना होता है। और अगर वो सेंट्रल लंग मास होता है तो आप ब्रोंकोस्कोप से उसको इजीली अप्रोच कर सकते हैं। Then the answer for the question would be the current question, the version which is given is bronchoscopy with biopsy. Dr. Putin, that was CT guided biopsy. Okay, good job. I think most of the guys would have got this concept right. The bottom line is, whenever you have a central lung cancer, you are supposed to identify it, get a tissue diagnosis by doing a bronchoscopic biopsy, and if it's a peripheral lung cancer, you would be going in for a CT guided biopsy. Differential diagnosis of a central lung mass, doctor, I think in terms of squamous cell cancer, and all lung cancers that begin with S associated with smoking, squamous and small cell are central in location. So I would like to go for it. And Dr. Cytology ka, I would say, okay, two issues coming up. One is Dr. Gowri has a good point. Why did you not do a cytology before going in for a bronchoscopy? You see, doctor, the diagnostic yield of cytology would not be very good. If you read the language of the question, he says next best step for the patient. So I need something where I can tell the patient conclusively that, okay, I have determined you have a cancer of this XYZ variety. So if I want to find out what is the tissue diagnosis in the patient, I need to go for a biopsy. Sputum cytology is good only for one lung cancer, that is adenocarcinoma. That is because the lung cancer cells will have a transbronchial spread. जो मैं ऐसे डायग्रामेटिकली अगर रिप्रेजेंट करूं कि ट्रेकिया है, ब्रोंकस है, और आगे सेगमेंटल ब्रोंकस है, सब सेगमेंटल ब्रोंकस है, तो जो अडीनोकार्सिनोमा होता है वो एक पेरिफेरल लंग कैंसर होता है. इट हैज अ ट्रांस ब्रोंकियल स्प्रेड, सो सम ऑफ द लंग कैंसर सेल्स वुड बी कमिंग अप इवन अप टू द ट्रेकिया. सो स्पूटम साइटोलॉजी वुड बी हैविंग अ यील्ड here. No, doctor, sputum cytology can help you identify lung cancers as well. You can spin the sputum sediment में cytology को देख सकते. Okay, great, Abhinav. Great. If you are putting on headphones and listening to me while walking, that would be simultaneous exercise as well. Vandana says, what is the next investigation? Sir, if I have a lung mass तो मुझे tissue diagnosis करना पड़ेगा ना. मैं best word हटा भी दूँ तब भी sputum cytology नहीं है. आपको जो अगला step करना है, अगर आपने lung mass identify किया, suppose X-ray में किया कि there is some mass available visible on a digital chest X-ray, I still need to go for a tissue diagnosis. तो X-ray के बाद में मैं CT करूँगा उसके local spread को देखने के लिए, and then subsequently depending on it's central or peripheral, I can either CT के साथ में ही उसी session में if it's a peripheral one, I can in the same session when I'm doing a CT, I can do a CT guided biopsy, or subsequently I can be going ahead with the management of the patient. Doctor, cytology is the first step but is not the best step. If you've identified a lung nodule or a lung mass in a patient, tissue diagnosis is to be done. Expect questions in NEET from this marathon. Doc, we cannot expect questions, but yeah, the topics would be identified or topics would be asked. Dr. Pradyun says, why did you not use the CAB approach? Yeah, doctor, I used the CAB approach. We need to go in for chest compression, but सीधा chest compression नहीं देते ना डॉक्टर. पहले आप देखो तो सही कि वो उसको वो ऐसा तो नहीं है कि हाइपोग्लाइसीमिया से कोलैप्स कर गया या प्रोलॉन्ग स्टैंडिंग की वजह से उसको वेजोवेगल सिंकोप हो गया. एल्डरली जेंटलमैन है, उसको हो सकता है कि फर्स्ट डिग्री हार्ट ब्लॉक हो या सिक्स साइनस सिंड्रोम हो और वो कोलैप्स कर गया, तो उसका तो ब्रैडिकार्डिया से सिंकोप हुआ ना, तो उसके लिए तो यू डोंट नीड टू गो इन फॉर चेस्ट कंप्रेशंस इन द पेशेंट. सो वी हैव स्टिल फॉलोड CAB, सर. इट इज CAB दैट हैज बीन फॉलोड. आई एम नॉट फॉलोइंग ABC here, so please do not be under any confusion. Dr. I think it was Dr. Mehrania. I hope it's very clear, sir. We're still following CAB in this question. Okay जी. Let's move on to the sixth one. I think काफी debate हो गया इस पे. Let's not troll each other, but yeah, Pratyush, you have a point. I mean, वो IAS officer जो था वो चेयर पे बैठे बैठे आदमी काफी CPR दे रहा था, तो that was a little funny. Okay. Atherosclerosis में atherosclerosis is a predisposition. No, doctor, Burgess is a separate disorder ना. Atherosclerosis and atherosclerosis large blood vessels को involve करता है, Burgess small को करता है. Okay जी, which of the following leads to a pulseless electrical activity? I'm getting B as an answer. तो सर वेंट्रिकुलर फिब्रिलेशन को पल्सलेस इलेक्ट्रिकल एक्टिविटी बोलते हैं क्या? वो तो शॉकेबल रिदम होता है ना. पल्सलेस इलेक्ट्रिकल एक्टिविटी के कॉज क्या होता है? द फर्स्ट कॉज फॉर पल्सलेस इलेक्ट्रिकल एक्टिविटी वुड बी एसिस्टोल. आंसर इज बी. आई एम गेटिंग अ डी. यार अब तो सिली मिस्टेक्स कर रहे हो. पल्सलेस इलेक्ट्रिकल एक्टिविटी का एक इंपॉर्टेंट कॉज होता है एसिस्टोल, फ्लैट लाइन इन द ECG. The next important reason why you could be having is a pulseless electrical activity could be empty heart. आपने ACLS का वीडियो नहीं सुना है, that means then could be empty lungs, then could be pressure on the heart, then could be pressure on the lungs which is squeezing the lungs from outside. Now let me explain this. When I say empty heart, what do I mean by the word empty heart is if a person is having circulatory failure, if a person goes into shock, then patient will become pulseless but heart will still be beating. Any variety of shock in an individual, hypovolemic shock, distributive shock, circulatory or septic shock, if there is no fluid in the body or it is redistributed, then the heart is beating, so electrical activity is there but patient is pulseless. What do you mean by empty lungs? That there is a blockage of the pulmonary artery by a big clot. The big clot that could be obstructing the pulmonary artery could be a sequelae of deep vein thrombosis, that is pulmonary embolism in the patient. Then what do you mean by pressure on the heart? The meaning of the word pressure on the heart is cardiac tamponade. That is an example of obstructive shock, that filling of blood in the heart would be affected. And when I say pressure on the lungs of the patient, pressure on the lungs would mean that there would be a tension pneumothorax which would be contributing to this. So when I say pulseless electric, because tension pneumothorax mein kya hoga? The positive pressure will crush the superior vena cava, inferior vena cava, and the venous return to the heart will be reduced. The answer to this question is not A. Aneurysm will max contribute to clot formation in the heart, and these clots can then go into the brain circulation and can result in development of stroke. So whether I have a plain aneurysm or if I have a pseudo aneurysm, possibility of clot and stroke could be there. Or I mean, most of the time when it comes to a LV aneurysm, a long-term complication, there could be a low cardiac output but not a pulseless electrical activity. If you say ventricular fibrillation, remember ventricular fibrillation and ventricular tachycardia are examples of shockable rhythm. We are talking about non-shockable rhythm. Answer is not A, it is not B. I think now you guys are getting it. Yes, Sakshi, this is from 5H and the 5Ts, but I have simplified this. I would suggest you to listen to the BLS and the ACLS video again in case you got 4 and 6 wrong. If you got 4 and 6 correct, cool. If you listen to ACLS, you will notice we've divided the discussion into two. That is going to be a shockable and a non-shockable rhythm. When I talk about non-shockable rhythm, it is pulseless electrical activity. It could be empty heart, empty lungs, pressure on the heart, pressure on the lungs. That's how you can remember it. I mean, 5H and 5Ts are difficult to remember. The correct answer for question number 6 is option number C, that is pulmonary embolism. Doctor, ventricular fibrillation, ventricular tachycardia, they would be having a disordered electrical, they are example of shock. We are talking about PEA. The causes of PEA is what I've elaborated here. King Kumar, I think you would have mailed me. I cannot check the mail at the moment. My email is marwamedicine@gmail.com. So you can drop me a mail. I'll respond to you. You can send me your mobile number also there and I'll try to revert back to you. Differentiate points between shockable and non-shockable rhythm. Okay, sir, pretty straightforward. I mean, any patient who collapses, I mean, in ACLS protocol, any patient who will collapse, what you need to do is deploy a AED. That's the beauty of technology. He says, don't try, a doctor trying to differentiate between shockable and non-shockable rhythm would be a waste of time and resources. So he says, put on the AED and this AED then decides. So we are using technology. When I say shockable rhythm, the ECG of the patient would either be showing this kind of a presentation. Let me just draw it before you, that broad QRS tachycardia with a classical Josephson sign that I describe every time. Or it's going to be a ventricular fibrillation like this. Or when I say non-shockable rhythm, the computer says shockable rhythm detected, or it's not going to fire non-shockable, then the ECG will be a flat line. And if it's not going to be a flat line, then you need to consider all those aspects that I mentioned. That is, the person could be having is an empty heart, or I mean, there are two important organs which are to be considered: heart and lungs. And there are two words to be remembered: empty and pressure. So when I say empty heart, it means shock. When I say pressure on the heart, I mean tamponade. If I say empty lung, that means pulmonary embolism. If I say pressure on the lung, that means tension pneumothorax. I hope you got it, guys. I'll repeat it again. If I say empty heart, shock. If I say pressure on the heart, tamponade. If I say empty lungs, that means pulmonary embolism. If I say pressure on the lungs, it means tension pneumothorax in a patient. So AED does a rhythm check here. You use technology to your advantage, because otherwise you would not be able to differentiate between the two. So there's already a session available on YouTube on my channel, so you can refer to that where I've covered it. The correct answer for question number 6 is option number C. And in case you got it correct, great. In case you got it wrong, it's not that you don't know it, you've all read it. It's just that in that 1 minute or 40 seconds, you need to get the data right. Okay, ji. Cool. Moving to the 7th one. Let's check out your reflexes once again. Which of the following steps is not useful in management of a patient of pulseless ventricular tachycardia? We are having a chap with PVT. And he says heart block. Sneha, that's आप rapid revision में देख लीजिए, वरना आगे के sessions में मैं explain कर दूंगा the types of heart block in a patient. Sir, heart block से तो bradycardia होगा ना डॉक्टर साहब? If a person has a complete heart block, that complete heart block would contribute to bradycardia and will contribute to hypotension, but it is not going to cause the patient to become pulseless. And complete heart block में तो you get ECG findings ना, electrical activity. There's a bradycardia. He's not pulseless. Heart rate of the patient could be 40 or 30 or 35, but it's not that he is pulseless. Okay, defibrillation is not given in pulseless electrical activity. You treat the cause. If it is asystole, adrenaline. If it is empty shock, IV fluids. If it's empty lungs, there is thrombolysis. If there's tamponade, it's a pericardiocentesis. If it's a tension pneumothorax, it's a wide bore needle decompression. So 5H and 5Ts have been simplified here, and you need to treat the cause. Okay, I'm having good answers. Gauri has come up with a good input there. Let's look at what you guys are saying. He says all the following steps is not useful in management of a patient of a pulseless vent. Yes, Dr. Pradhyun, it will contribute to a S1, Q3, T3, definitely yes, and a heart strain sign on the ECG. Not in all cases, no, not the, you could be having a sinus tachycardia also. And finally, I mean, you see, Pradhyun, you have a point. That is the initial part. Once the patient's blood supply to the lungs is zero, let us assume patient is having, let me just answer Dr. Pradhyun and we'll come back to this. He says, would you not get that ECG finding a right heart strain? See, doctor, once pulmonary embolism, like a saddle embolus. जैसे हमने कोविड में देखा ना यार, कोविड इज अ hypercoagulable state. We lost lot of patient COVID where we had a big clot in the pulmonary artery. Echo में हमें दिखाई दे रहा था, but we are not able to do anything for those patients. There is a clot dancing in the pulmonary artery. Big clot. तो वो तो blood supply cut off कर देगा ना, तो blood supply cut off ही कर देगा, तो then the person will become pulseless in that circumstances. Okay जी. We come to question number 7 in this case. So you have a valid point, but my point is a delayed presentation of PE or a delayed diagnosis of PE will make the patient pulseless. For a pulseless ventricular tachycardia, which of the following steps would not be useful? So pulseless ventricular tachycardia के लिए 3 ऐसे boxes बना लीजिए जैसे मैंने आपको सिखाया हुआ है, और बीच में ऐसे हम ये DC shock देंगे. टोटल 3 बार DC shock देते हैं. In any patient of pulseless ventricular tachycardia, you are supposed to give 3 DC shocks to the patient. So that has been put up. And when I say DC shock, you deliver defibrillation to the patient. अभी भी hint तो दे दिया है, but still अगर नहीं समझ में आ रहा तो आगे सुनो. फर्स्ट बॉक्स में आप क्या करते हो? आप IV लाइन लगा देते हो. CPR तो देना ही देना है. I'm not writing CPR in any situation, but you doing CPR, you given 1 DC shock, no improvement, you continue CPR, put in IV line. The next thing that you do in the patient is using this IV line in the patient, you will be giving epinephrine. The reason why we give epinephrine in pulseless ventricular tachycardia is to increase the coronary perfusion. इसके साथ में हम इंट्यूबेट भी कर देते हैं, that is advanced airway. और इसके साथ में यहाँ पे जो थर्ड बॉक्स है, थर्ड बॉक्स में जो दवाई हम दे रहे होते हैं फॉर अ पल्सलेस वेंट्रिकुलर टैकिकार्डिया इज एम्योडारोन. द करेक्ट आंसर फॉर दिस क्वेश्चन इज कार्डियोवर्जन. हम डिफिब्रिलेशन करते हैं सर, कार्डियोवर्जन नहीं करते हैं. एंड मोर इंपॉर्टेंटली आई मीन दिस टेबल फॉर ACLS, ventricular tachycardia and ventricular fibrillation, what I explained. I mean the 3 boxes, what are the interventions that you're doing? In the first box, you're just getting the IV access. In the second box, what you're doing is, it will become a little blurred, but the point is in the second box, you're giving epinephrine to the patient. Why do we give epinephrine? I mean, the usual query from those who would be listening to for this first time is, sir, epinephrine is in cardiac arrest. Why in ventricular tachycardia? We give it because it causes vasoconstriction, and it has been documented to cause a slight increase in coronary perfusion. तो आप बोलोगे सर उससे क्या हो जाएगा? If I increase, ना patient is so bad condition, VT occurring, VFib occurring, and you saying coronary perfusion बढ़ जाएगा. Sir, it will reduce hypoxia. And if I reduce the hypoxia component of the heart, then the fibrillation or tachycardia का cause ही hypoxia होता है. I mean, why do you have triggering of VT or VFib? It is because of the hypoxia component. So I give epinephrine here not to stimulate the SA node. In cardiac arrest, I give epinephrine to stimulate the SA node, get the rhythm back to normal, get a normal sinus rhythm. Here I don't want NSR. Here I want to just increase coronary perfusion. And why do you give amiodarone and lignocaine in the subsequent part is, I mean, with respect to the third DC shock, is that they tend to increase the response to DC shock. I mean, the textbook says that the advantage of using these drugs is that they improve the response to electroshock. Now, electroshock is something which I'll say to a non-medico. Because for you guys, you need to understand cardioversion or defibrillation एक ही बात नहीं होती है. Cardioversion is what you would be using with respect to PSVT or atrial fibrillation in case you need to convert it to normal sinus rhythm. Cardioversion का मतलब होता है synchronized DC shock where there is a peak of R wave. यहाँ पे तो peak of R wave होता ही नहीं है. We use defibrillation for the patient. We do not use cardioversion. The correct answer for question number 7 that I'm discussing with you is option number C, advanced airway. You need to intubate because intubation से फायदा क्या होगा? Hypoxia will become lesser and therefore VT will become lesser. Amiodarone, again, the advantage of using amiodarone is it increases the responsiveness to electroshock. Epinephrine improves coronary perfusion / improves responsiveness to electroshock. The correct answer in this case would be C, so 200 joules is the answer for adults. Okay, 7 we are sorted. Dr. Ranjana says difference between. Yes, doctor, that is what I'm talking about. Shock refractory VT, that's what we are talking about. Shock refractory. We are gonna use pharmacological intervention. The intervention that I'm going to use if I have a electroshock resistant VT is I'm going to use epinephrine, I'm going to use amiodarone or lignocaine, whichever is available. Now, sir, dosage तो अब एग्जाम में नहीं पूछते ना, तो हम उस पर टाइम नहीं लगाते हैं. I mean, let's focus on more important things at hand. जैसे एक सवाल आया यहाँ पर कि Don't worry, sir. I mean, nobody remembers everything. The query is difference between cardioversion defibrillation. Just give me 30 seconds. मैं फटाफट से बोल देता हूँ. Cardioversion में हम क्या करते हैं? The computer fires the impulse with respect to the peak of the R wave. When I say peak of the R wave, I'm gonna draw a rhythm before you quickly, like a person is having a PSVT. तो PSVT में ECG कुछ इस टाइप से आता है, like I'm sketching at the moment. So in a patient having PSVT, R wave is visible. So computer can read this R wave and it can deliver a DC shock corresponding to the peak of the R, and it will cause resetting of the rhythm, और यहाँ पे rhythm normal sinus rhythm पे चला जाएगा. लेकिन डिफिब्रिलेशन, आप ये एरिथमिया देखो जो मैं अभी दिखा रहा हूँ, वेंट्रिकुलर फिब्रिलेशन, आर वेव है ही नहीं यार इसमें, तो पी क्यू आर एस टी यू कोई भी वेव नहीं है. अगर ऐसा ट्विचिंग होगा तो कंप्यूटर को समझ ही नहीं आएगा ना कि मैं कब फायर करूं. हमने कंप्यूटर के प्रोग्रामिंग करी थी कि भाई तुझे फायर करना है विद रिस्पेक्ट टू द पीक ऑफ द आर वेव, उसको बेचारे को समझ ही नहीं आ रही, तो कंफ्यूज हो गया. तो जहां पे कंप्यूटर पीक ऑफ द आर वेव को आइडेंटिफाई नहीं कर पाता है और हम यूज करते हैं नॉन सिंक्रोनाइज्ड डीसी शॉक, दैट नॉन सिंक्रोनाइज्ड डीसी शॉक इज व्हाट इज कॉल्ड एज अ डिफिब्रिलेशन. आपके लिए लर्निंग पॉइंट ये है एग्जाम के लिए कि डिफिब्रिलेशन कहां पे आंसर करना है, तो दो जगह पे, पीवीटी में और वेंट्रिकुलर फिब्रिलेशन में. इसको छोड़ के बाकी सब में, इसको छोड़ के बाकी सब में योर आंसर वुड बी cardioversion if required. But where do you use defibrillation? You wanna use it for a pulseless ventricular tachycardia and a ventricular fibrillation. सर एयरवे इज नॉर्मल, व्हाई इंट्यूबेट? सर कार्डियक अरेस्ट में अगर कोई पेशेंट जाता है या टैकेरिथमिया में जाता है, कोलैप्स कर जाता है, तो आई नीड अ प्रॉपर ओरिएंटेशन. सो इंट्यूबेटिंग द पेशेंट विल मेक सेंस बिकॉज आई विल बी एबल टू कंट्रोल द FiO2 डिलीवरी टू द पेशेंट. सर 280 नहीं करते, 200 जूल्स करते हैं. Sure, Dr. Ranjit, you can attend it subsequently also. PSVT, the drug of choice is adenosine. You are perfectly right. Let's move on to the next one. A 30-year-old patient, sir, my humble request to you guys is ये वाला जो टेबल है, VT, VFib, ये 3 DC शॉक, इसके स्टेप्स आपके माइंड में इम्प्रिंटेड होने चाहिए. और इसके सिवा this table, that SRS, AER, AED वाला, this should be imprinted. Okay, doctor, I hope I was able to explain this, and we move on to the next one. 30-year-old alcoholic male has come with complaints of multiple episodes of right upper quadrant pain. LFT shows serum bilirubin of 0.8, so that's pretty decent, but SGOT of the patient is elevated. And SGPT is still in the normal range, but SGPT shows a rise. PT of the patient as compared to control is again deranged. So I'm waiting for answers from you guys. I've had a D, ursodeoxycholic acid, so that would be for those patients who would be having cholestasis. I mean, normally when we would be using ursodeoxycholic acid would be with respect to cholestasis in a patient. My chap is not having cholestasis. He is having mild hepatomegaly, preserved echogenicity. What drug would be useful for management of the right upper quadrant pain of the patient? So let's look at the clinical diagnosis. You are having an alcoholic and the alcoholic is having an elevated SGOT. So the clinical diagnosis of this patient is alcoholic hepatitis. What I have asked before you can be a one-liner question. What is the drug of choice for management of alcoholic hepatitis? Okay, for people saying A, reduce alcohol intake, हम बहुत बार डिस्कस कर चुके हैं यार, अल्कोहल को धीरे धीरे छोड़ना होता है. Should you stop alcohol slowly or should you tell the patient to give up alcohol abruptly? Yeah, people saying A, please tell me, should you give up alcohol धीरे धीरे, like मतलब 1 bottle, half bottle, quarter, or should you abruptly give up? Yes guys, I am still waiting. सर सडनली होता है, एब्रप्ट होता है, विड्रॉल होता है, और विड्रॉल होगा तो जैसे ही अल्कोहल छोड़ेगा ना उससे डिलीरियम ट्रेमन स्टार्ट हो जाएगा ना, तो अपने आप से छोड़ भी नहीं पाते, धीरे धीरे छूटती ही नहीं है, और सडनली छोड़ने की कोशिश करते हैं तो डिलीरियम ट्रेमन्स हो जाता. तभी तो सर एडमिट करके आप उनको उनको डी एडिक्शन, अपने डी एडिक्शन सेंटर में एडमिट करके उनको नाइट्रेक्सन और एक एम्परसेट देते हो, क्योंकि खुद से नहीं छूटती है. द आंसर टू अल्कोहलिक हेपेटाइटिस इज स्टेरॉइड्स. I mean, if I wanted to ask you, how would you give up craving for alcohol, then disulfiram would make sense. So B, I'm ruling out because I'm not talking about craving today. Yep, thank you, doctor. And ursodeoxycholic acid is used if there is a cholestasis in a patient. if there is elevated serum alkaline phosphatase in a patient, there is no mention of any elevated serum alkaline phosphatase. Every time you have an alcoholic patient with elevated SGOT, it is alcoholic hepatitis which is to be considered. So to reduce the alcoholic hepatitis component, I will have to start steroids for this patient. Acamprosate is for de-addiction, doctor. Like suppose the question said what drug is used for de-addiction in alcohol, then it is acamprosate and naltrexone. Yes, doctor, the correct answer, Dr. Rajan, is option number A. Sorry, option number C, that is steroids are the drug of choice for management of alcoholic hepatitis. I'll repeat once again, why am I saying alcoholic hepatitis? पहला feature LFT में SGOT बढ़ा हुआ है, PT भी बढ़ा हुआ है. Both of them are components of alcoholic hepatitis. And Mallory hyaline bodies, yep, I mean, I'll not do a biopsy in these patients, but yeah, I mean, alcoholic hepatitis, if the person agrees for a biopsy, then yep, Mallory hyaline bodies can be present. Doctor, I'm not very sure, Dr. Mehul, for that. Yeah, discriminant score is used to check out the severity of alcoholic hepatitis, but the bottom line is कि भाई alcoholic है. मतलब सवाल आप समझ लो ना, अगर ये सवाल ऐसा होता कि alcoholic को अल्कोहल छुड़ाने के लिए क्या करेंगे, तो आपका आंसर होता naltrexone और acamprosate. क्रेविंग वाले एस्पेक्ट के लिए यस डाइसल्फिराम को यूज करते हैं. डी आंसर क्यों नहीं है? क्योंकि कोलेस्टासिस नहीं है, एलिवेटेड सैप इन दिस पेशेंट है. द करेक्ट आंसर फॉर दिस वन इज ऑप्शन नंबर डी. डॉक्टर ऐश्वर्या, द ट्रीटमेंट ऑफ चॉइस फॉर अल्कोहलिक हेपेटाइटिस इज स्टेरॉइड्स. प्रेडनिसोलोन. पेन मैनेजमेंट आस्क्ड. हाँ जी सर, वो राइट अपर क्वाड्रेंट डिस्कम्फर्ट है ना, उसको तो हम हेपेटाइटिस का कंपोनेंट मिनिमाइज कर देंगे. एंड ऑप्शन नंबर ए मैंने एक्सप्लेन किया. या डॉक्टर एबीजी क्वेश्चंस, या डॉक्टर यू मेटाबॉलिक एसिडोसिस में तो करेक्शन सभी में करना है ना सर. रेस्पिरेटरी एसिडोसिस में 10:1 का फॉर्मूला लगाना होता है, एक्यूट में, क्रॉनिक में 10:2 का होता है. पढ़ना यानी जो आपका रैपिड रिवीजन में एबीजी वाला कंपोनेंट है, उसमें मैंने बताया कि फॉर्मूला कैसे लगाना है. विंटर्स फॉर्मूला फॉर मेटाबॉलिक एसिडोसिस. वन क्वेश्चन फॉर वाई सर. ओके डॉक्टर टिगरी, द ड्रग ऑफ चॉइस अल्कोहलिक हेपेटाइटिस जो है दैट इज अ प्रिकर्सर टू अल्कोहलिक सिरोसिस. क्योंकि इसके बाद में इसका लिवर, अभी तो देखो इसको हेपाटोमेगाली है ना, इसके बाद इसका लिवर जो है वो श्रिंक कर जाएगा, तो वो हेपाटोमेगाली से जो श्रिंकेज वाला प्रोसेस है उसमें जो जो साइटोकाइन इंड्यूस्ड डैमेज है या जो भी इंफ्लेमेटरी चेंजेस इन द लिवर है उसको मिनिमाइज करना है. ओके निखिल, नो नॉट अ प्रॉब्लम. In case of hepatitis C, more issues will be there. Absolutely. Okay, guys, we sorted for question number 8. We had to spend a lot of time for it. I thought it will be relatively easy for you because when we started the discussion, what I found was the responses were much better. Now I think the responses, the correction went down. The correct answers went down a bit. Dr. Pradeep says how to calculate the discriminant score. So, doctor, there are two parameters, serum bilirubin and INR, that would be used. There's a statistical formula for it. In fourth year, sir, the paper was also hard. So, I think Dr. Strange, not Strange, the query that you put up, paper was really hard. So, I think you should persist with this. डॉक्टर एम ए सैग क्लासिफिकेशन आप आरआर से देखो एक बारी और फिर मुझे रिवर्ट करो इसके ऊपर. अगले क्वेश्चन पे आते हैं. 60-year-old man is having multiple episodes of maroon color stool. Workup of colonoscopy was done and fecal occult blood test is positive. FOBT is fecal occult blood test. And then he's saying that what could be the possibility in this patient? सर ये वाला क्वेश्चन तो yeah, Dr. GB, we should be giving it if the score is high, but yeah, I mean, if I'm having a deranged SGOT, if I'm having a deranged PT in the patient, then the MELD score will turn out, then the discriminant score will turn out to be high and I'll use steroids. Okay, I am still getting multiple answers for this one. Let me repeat this. A maroon colored stool for last 1 year, so multiple episodes of blood in the stool is present. the colonoscopy of the patient is normal. That means that maybe, usually when we do a colonoscopy, we expect some lesion to be present, but no lesion was present in this case, and colonoscopy was done 2 times and it was turning out to be normal, but still the fecal occult blood test is positive. Now, for people who are saying this could be inflammatory bowel disease or it could be cancer rectum, if the weight of the patient is normal at the moment, the bowel habits of the patient are normal, there is no constipation, it is very, very unlikely that in this particular case it would be inflammatory bowel disease and cancer rectum. At least in cancer rectum, I can say one, even if the first colonoscopy was normal, the second colonoscopy is unlikely to be normal because at least it will create some cauliflower-like growth which can be picked up. तो कैंसर रेक्टम तो कोलोनोस्कोपी पे विजिबल हो जाएगा. अनदर पॉइंट इज कोलोनोस्कोपी अगर कैंसर है तो यार कैंसर में तो कैकेक्सिया हो जाता है. I mean, 1 year is a very long time. I said in last 1 year he has got colonoscopy done 2 times. So if it was a cancer which is undiagnosed, his weight would have progressively reduced. So this is very unlikely as an answer. And if I say inflammatory bowel syndrome or inflammatory bowel disease in a patient, again lesions of colitis being missed or proctitis being missed, because most of the time when I say blood in the stool, maroon colored stool, I'm thinking about ulcerative colitis. So proctitis miss हो जाए colonoscopy पे दो बारी, again very, very unlikely. So I'm left with irritable bowel syndrome and AV malformation. So irritable bowel syndrome में तो blood आता ही नहीं है ना. There is no blood in the stool in irritable bowel syndrome. So I think मैंने सिर्फ थोड़ा सा क्वेश्चन को ट्विस्ट किया यार. ये तो I think was a very easy question. It was angiodysplasia of the colon. उसकी जगह पे लिखा AV malformation. The correct answer for this one is option number D here. So I think that we should not have had so much of confusion with respect to this particular question. I'll rule out the options quickly once again, 30 seconds. Option number C is the easiest to rule out because you get cachexia and the cancer should be picked up by a colonoscopy. So is the lesions of proctitis with respect to ulcerative colitis, which is common in India as compared to Crohn's, which is more common abroad. And again, inflammatory bowel disease, if the blood loss is substantial, weight loss would occur in the individual, anemia would set up. बी सर जो आंसर आया था वो इसलिए रूल आउट किया है बिकॉज इरिटेबल बबल सिंड्रोम में तो ब्लड आता ही नहीं है स्टूल. देयर इज नो ब्लड इन द स्टूल इन इरिटेबल बबल सिंड्रोम. उसमें तो अल्टरनेटिव कॉन्स्टिपेशन, डायरिया, टमी पेन रहता है. सो द आंसर बाय एक्सप्लेनेशन बाय एक्सक्लूजन इन दिस क्वेश्चन इज ऑप्शन नंबर डी. Let's do the next one. We have this Dr. Shubh Mangal says, can't we see AV malformation on a colonoscopy? The issue is, doctor, that those AV malformations can be having pinpoint bleed and they may not bleed on the day you have done a colonoscopy in the patient. So because one, they are not bleeding on the day and they might be having a pinpoint bleed, AV malformations can be, there is a high probability that they can be missed. That is the reason why for picking up a malformation, we need to do a CT angio. I mean, we can either do a CT angio or we can do a MR angio in a patient. Like he says, how do you pick up or what is the next best investigation to confirm whether it is a AV malformation? Then we'll be doing a CT angiography in the patient. Coming to the 10th one that we're discussing, relatively a easier one. Riksha Puller is having early satiety, recurrent vomiting episodes, significant weight loss, lump in the epigastrium, hard inconsistency. So we straight away, I mean, we are localizing the lesion in the stomach. So this would be a stomach cancer. Peptic ulcer is not going to contribute to a lump. Similarly, pancreatic cancer most of the time would contribute to obstructive jaundice in a patient, but unlikely to cause a lump like this. And then abdominal tuberculosis will cause a lump in the ileocecal area. So the remaining options are, I would say, relatively easier to solve. So 10 is sorted. I'll move the slide to the 11th one. We have this alcoholic, 50 years of age. He's having repeated episodes of epigastric pain. He has puked 3 times in last 1 hour in the emergency room. There's a tachycardia. BP is doing fine at the moment. There is a pallor, dry tongue, extreme tenderness in the epigastric area. So we need to do a CT angio in the patient, and most of the time excision has to be done of the part where the AV malformation has to be done. So there would be a, I mean, the resection of that particular part of the bowel where AV malformation is present. Okay, thank you, doctor. We are having an alcoholic with multiple episodes of epigastric pain and vomiting, and he says what would be the differential diagnosis in this patient. Acute cholecystitis should be causing a right upper quadrant tenderness, whereas in the question it is a epigastric tenderness in the patient. There is no evidence of any Murphy's sign in the patient as well, so unlikely that this would be a cholecystitis. People saying Mallory-Weiss syndrome, Mallory-Weiss में तो there should be vomiting of blood. This particular question is not having vomiting of blood. In fact, when you said Mallory-Weiss तो मैं ही confused हो गया, मुझे लगा यार कहीं blood bleeding तो नहीं लिखा. He is having episodes of epigastric pain and vomiting. So the diagnosis of this patient is not Mallory-Weiss. A Mallory-Weiss guy will puke blood. Here there is no puking of blood. He is just having vomiting. That could be acute pancreatitis. And बाकी भी तो पढ़ो ना सर. पर abdomen में tenderness है. There is rebound tenderness is absent. There is no evidence of free fluid in the abdomen. वो सारी चीजें उसने बाकी चीजें rule out करने की कोशिश करी है. Portal hypertension again will contribute to hematemesis. The correct answer for question number 11 is option number C. That would be acute pancreatitis. Yep. Portal hypertension does contribute to it. Okay, let's move on to the 12th one. So it's gonna be mixed bag questions, guys. Some of them are gonna be so simple that you will be wondering, I mean, why the hell did I do, so much of study for? And some of them are gonna be tongue twisters or are gonna, cause errors of judgment. Nikhil Raj, in subsequent sessions, today we are not doing ABG questions. If you want to go for ABG, the previous session is where I have done them. Let's move on to the next one. 65-year-old chap, sudden onset right arm weakness with aphasia for last 6 hours, and a standard stroke presentation is there. The CT head of the patient is normal. There is a M1 segment occlusion of middle cerebral artery because obviously there's an arm weakness with aphasia, so it is middle cerebral artery that would be involved. Which of the following is the best management for this patient? Okay, fine. I'm getting an A and a B and a C. So let's start with A. Start enoxaparin, loading dose of aspirin and high intensity statins in a patient. Okay, let me just explain. If CT angiography of a patient is showing occlusion of an artery, even if the CT of the patient is normal, the clinical diagnosis of this patient is acute ischemic stroke. And if you're having acute ischemic stroke in a patient, there are two things which can be done. One is thrombolysis and second is a mechanical thrombectomy. The presentation in this patient is for previous 6 hours. So I can do thrombolysis, but it's a little late for doing thrombolysis in the patient. Yeah, Avinash, you are right about what they do, but before I show you the algorithm, I can just say that you should be aware regarding the branches of the middle cerebral artery. This is a separate animation in the neurology section that I made for the branches. The M1 segment is the one which would be supplying the basal ganglia, और यहाँ से internal capsule भी जा रहा होगा. So there is a possibility that in this chap, the M1 segment got involved and then the internal capsule got involved. And as a result of it, there was I'm saying speculating at the moment that this could have resulted in, at least the face weakness in an individual, though this will not contribute to aphasia. Then subsequently, there's a M4 branch, the cortical branch, and that cortical branch जब involve हो जाती है, अगर cortical branch की भी, क्योंकि M1 बंद हो जाएगा तो M4 का supply भी बंद हो जाएगा, और M4 का supply बंद हो जाएगा तो cortical branch का, तो then the manifestation of aphasia can be understood in this particular case. So one, there is a big time clot which has occluded the blood supply downstream, the M2, M3 and the M4 segments. So the algorithm is like this. If the patient presents between 6 to 24 hours, there's a CT angiography which is showing a presence of occlusion of the middle cerebral artery, or CTP is showing a perfusion deficit, then we will be doing a thrombectomy in the patient as far as the flow chart is concerned. If I go back to the options here, and he says which of the following is the best management for this case, the best management for this patient following the algorithm that I've answered would be option number C, that is schedule a thrombectomy for the patient. Yes, Dr. Kishore, you pointed out very well that C would be better as compared to B for this question. Okay, good job. So we are sorted with 12 and the window period is still 4.5 hours, but he's written in Harrison a line that thrombolysis can show some benefit between 4.5 to 6. He's written may show benefit between 4.5 to 6. So there's a slight change in a sense that if you listen to the older version, I have said do mechanical thrombectomy after 4.5 hours. But currently in the current version of the textbook, he's saying that after 6 hours do a mechanical thrombectomy in the patient. Yes. In hemorrhagic stroke, Dr. Ankit, we have to control the raised ICP of the patient. So that would be with mannitol or ventriculostomy, or if it's a brainstem bleed or a cerebellar hematoma, then we might have to go for a decompressive hemicraniectomy in the patient. Yes, Dr. Roy, if this patient presented relatively earlier, I would have done a thrombolysis in this patient. Okay. Yeah, Dr. Vandana, that's what I'm trying to show you, know, that in the older edition of the book, he was very pertinent about thrombolysis being done only till 4.5 hours. But this is a table from the 21st edition of Harrison that I have tried to, I have tried to explain in the rapid revision component also that the statement is ideally done in 4.5 hours and is written may show benefit from 4.5 to 6, which was not written previously. And because they've given a flow chart like this, so you have to answer up to 6 hours. That would be thrombolysis. If he's ineligible for it, then it's a separate issue. There are contraindications for thrombolysis, like a previous hemorrhagic stroke. Then you'll not do thrombolysis in a patient. But yep, that's the new table. So I thought I'll just bring that to your notice once again. Yes, Ankit, that's what I'm trying to say. If there was no thrombectomy in this question, your answer would have been thrombolysis. Yep. Raghav, thrombectomy is done both in cases of within 6 hours. There is no window period for thrombectomy. Thrombectomy can be done up to 24 hours. Thrombectomy, if you're saying no window period, I think I missed that question. Yes, Raghav mentioned that what would be the window period that you will be doing thrombectomy, then it would be up to 24 hours. Either of the two can decide, doctor. He's written no CTA/CTP, whichever is available. CTA तो contrast तो push करना है ना, तो CTA would be easily available. Raghav, the upper limit for doing a thrombectomy is 24 hours. Okay, fine. So we are sorted with question number 12. I have shown the reference from the table as well before you. Let's move on to the 13th one. We have this 20-year-old patient and yep, Harrison reference. A 20-year-old patient went on a camping trip. Anatomy. Sir, अभी ये वाले क्वेश्चन कर लेते हैं. 20-year-old patient went on a camping trip and developed diarrhea, 15 episodes of loose motions in 3 hours, prostration, extreme fatigue with cramps in the legs. तो ऐसे ही होगा. एक क्वेश्चन होगा जिसमें ट्रिकी ऑप्शंस होंगे, एक बहुत सिंपल वाला होगा. सर 24 आवर्स के बाद में तो irreversible severe डैमेज है, तो आई मीन देयर वुड नॉट बी एनी इंप्रूवमेंट इन द कंडीशन ऑफ द पेशेंट. तो डायरिया हो गया पेशेंट को, तो डायरिया में हमेशा हाइपोकलीमिया तो होता ही है. देयर आर 3 ऑप्शंस विद हाइपोकलीमिया. And what is happening in this chap is there is loss of water. I mean, every time you have gastroenteritis, there would be decrease in total body water, decrease in total body salt. So that would be a hypovolemic hyponatremia with a hypokalemia. The answer to this question would be option number A. Good job. I think everybody went through the exclusions part very fast. 13th we are sorted. I'm moving to the 14th one. मेटाबॉलिक एल्कोलोसिस. नहीं डॉक्टर, डायरिया में तो मेटाबॉलिक एसिडोसिस होता है. विच सिचुएशन? ऑप्शन नंबर सी, हाइपरवोलेमिक हाइपोनाट्रीमिया. सर वो हाइपोकलीमिया वाला कंपोनेंट भी मैं एक्सप्लेन कर दूंगा, बट हाइपरवोलेमिक हाइपोनाट्रीमिया कहाँ पर होगा? तो दैट वुड बी सीन इन कंजेस्टिव हार्ट फेलियर, सिरोसिस और नेफ्रोटिक. और अगर आपने इन पेशेंट्स में थाइजाइड डायूरेटिक स्टार्ट कर दिए तो साथ में हाइपोकलीमिया भी हो जाएगा. इफ यू हैव अ कंजेस्टिव हार्ट फेलियर पेशेंट एंड सिरोसिस एंड नेफ्रोटिक सिंड्रोम, यू वुड हैव इज अ हाइपरवोलेमिक हाइपोनाट्रीमिया. एंड इनमें से किसी भी पेशेंट में अगर आपने थाइजाइड स्टार्ट कर दिए साथ में, बिकॉज वी गिव स्पार्नोलैक्टोन इन मेजॉरिटी, लाइक इन सिरोसिस असाइटिस वी गिव स्पार्नोलैक्टोन, सो यू डोंट हैव अ हाइपोकलीमिया. बट या इफ यू यूज थाइजाइड्स, देन ऑप्शन नंबर सी somebody put up. I mean, why would you be having option number C? Then heart failure, cirrhosis, nephrotic would contribute to that. Euvolemic would be mainly SIADH, but there would be no hypokalemia component present, which is mainly for this particular question. Yes, Dr. Aziz, you're right. Let's move on to the 14th one. This 90-year-old chap is having recurrent episodes of dizziness and syncopal episodes, ECG and chest X-ray is shown. So what is the device present here? It's not a chemoport because chemoport would be for chemotherapy, and we are having or expecting a cardiovascular event in this case. Vagal nerve stimulation is done in patients who are having medically refractory epilepsy. So two options I've ruled out for you guys. And now your job is to tell me that what you are seeing is a defibrillator or is it a pacing device in a patient. And okay, absolutely. Look at the ECG of the patient. ये जो vertical lines आ रही है ना ये वाली, I think अब मैं vertical arrows दिखा देता हूँ. ये pacer spike होती है ना सर. This is a pacer generated. देखो ना, there is no P wave present क्योंकि pacemaker heart का rhythm generate कर रहा है ना. तो it is causing this really broad RS complex. It's causing a real broad RS complex in a patient. So the point is ये जो vertical lines हैं, these vertical lines that you're seeing is pacer spikes. This is not a ICD sir. ये जो ECG है, ये ECG हार्ट ब्लॉक की भी नहीं है. पेशेंट को तो 6 साल ओल्ड एज में 90 साल पे कौन सा हार्ट डिजीज कॉमन होगा? तो 90 इयर्स पे अगर किसी को डिजीनेस हो रही है तो कौन सा हार्ट डिजीज कंसिडर करोगे? 90-year-old man comes to you with dizziness and syncopal episodes. What will you consider? The first disease that you will consider will be sick sinus syndrome. In old age, we usually have recurrent syncopal episodes. If cardiac cause is found for syncopal episodes, it's mainly a sick sinus syndrome in a patient. And for that, we have to deploy a pacemaker. So this is a pacer and pacer spikes can be seen. The correct answer to this question is beta. And I mean, X-ray देख के नहीं बता सकते हम कि ये pacemaker है या ICD है ना? हमें ECG पे rely करना था. ये वाला जो right वाला image है, ये तो clear cut distraction है. I mean, by X-ray we can't say it is a pacemaker or it is the implantable cardioverter defibrillator. It is the ECG that would have told us. Okay, Dr. Doody, I'll speak mainly in English. What I'm trying to say is by help of an X-ray, we would not be able to identify whether it's a pacer or whether it's a ICD. It's mainly gonna be the ECG that would help you, and because you can see pacer spikes in this case, so we are gonna answer this as option number beta. Dr. Kohli said cardiogenic shock in case of Takotsubo, use IABP. Yep, doctor, we use that. We use impeller device for the patient. Yep, same, Ankit. It would look almost the same. Yep. Implantable, Dr. Meet Patel, if it's a ICD, no, then ICD will deliver it. So you will be able to see, like suppose I give you a ECG in which you can see a run of tachyarrhythmia. Suppose there was a ECG given in which there is a tachyarrhythmia occurring and then there is a normal sinus rhythm. Like suppose, आपने पूछा तो, you know, I'm gonna just make it like this. Suppose I gave you a ECG like this. There is a broad QRS tachycardia. And then there is maybe a artifact like this present, which is where the DC shock was delivered, and then normal sinus rhythm was established in a patient. If this was the kind of a representation, then I'll say it is an implantable cardioverter defibrillator. The patient had a tachyarrhythmia, because where do you put a ICD? You put a ICD when there is a tachyarrhythmia in a person. And where do you put a pacemaker when there's a bradyarrhythmia in a person? So in an old chap, dizziness syncopal episodes, because I'm thinking in terms of possibility of the fact that there is a sick sinus, so pacing is the answer. Vivek said leads, number and location. Sir, there's a separate video for pacemaker. I mean, if you want to read about the type of pacemakers, demand, on-demand pacing, etc. And dual chamber pacing, etc. The details of it, just search pacemaker with my name and you'll get a video on the same. No, Ankit, let's not get into the X-ray part here. It would be more than sufficient, Dr. Ravi, if you go through RR 3.0, absolutely no issues. Okay. बट अब 4.0 इस में थोड़ा अपडेट्स आया है, तो अगर आप उसको देख लो 2x पे, एक बार 3.0 कर लो, एक बार 4.0 कर लो, दैट्स इट. ओके, मूविंग टू द नेक्स्ट वन. We are having a patient. Hi, Dr. Rahul. We are having a smoker who's having a blood-stained sputum during cough on workup. Chest X-ray is normal. I mean, majority of the time in any patient with hemoptysis, X-ray will usually be normal. He says, what is next to be done in a patient? Considering that my patient is a smoker, I am suspecting that he could be having a lung mass. So I'll be doing a CT chest in this patient, and following a CT chest, like suppose the question had himself mentioned CT chest is done in the patient, what would be done next? Then it would be bronchoscopy. Every time you get a question on hemoptysis, remember you need to check it out whether he's talking about non-life threatening or is talking about massive hemoptysis in a patient. If the question is talking about massive hemoptysis, then your main objective nowadays is send the patient to interventional radiology, and they will do is a bronchial artery embolization. They inject a gel to control the bleeding. But if it is a non-life threatening hemoptysis in a patient, then the algorithm is chest X-ray. Along with this, subsequently a CT, and then subsequently a bronchoscopy to localize the lesion and treat the cause. I mean bronchoscopy, and then you treat the cause, whichever is responsible. Okay. Ankit, which one did you do wrong? I could not follow that. So answer to 15 is option number C. We move to the next one. Again, the question is what I have twisted it here. So rigid bronchoscopy, yep. Tuberculosis would usually cause a massive hemoptysis. And if it is massive, then bronchial artery embolization. So for tuberculosis, see if it's a massive hemoptysis, I'm not worried doing a sputum test at that moment. But the person is in dire straits, I need to save his life. Sir, it's always a flexible bronchoscopy. We always in lungs want to do a flexible bronchoscopy. Only time you do a rigid is for foreign body removal, no? Or if there is a massive. But nowadays in massive, he says why to do waste time with doing a rigid bronchoscopy, because you would not be able to control the bleed, because maximum after rigid bronchoscopy you can do is a balloon tamponade. So with balloon tamponade, as long as the balloon tamponade effect is there, the bleeding will stop. You remove the balloon, the bleeding will again occur. So he says instead of trying to do I mean, you can do it. I'm not saying that that's not a good approach. A lot of people tend to, handle massive hemoptysis by doing a rigid bronchoscopy with a balloon tamponade, control the bleeding, shut down the bleeding, बाद में देखेंगे. But in an era where patient will want a quicker resolution of his problem, he says take up the patient in a interventional neuroradiology suite, do a angiography, demonstrate which branch of bronchial artery is bleeding in a documented case of TB, and then do a bronchial artery embolization. Bleeding is not from pulmonary veins, sir. Most of the time in TB, the bleeding occurs from bronchial artery. If it is from vein, it will not be life-threatening, no? If it is a non-life threatening hemoptysis, you don't need to do anything in the patient. I mean, there is no need for balloon tamponade, there is no need for any cautery, there is no need for any embolization to be done. Okay. Coming to 16th, we have this chap, modified this question a bit. We are having a smoker, venous bleed up is not a concern. We are having a smoker with episodes of non-life-threatening hemoptysis, and he's also having Cushing syndrome. So we are thinking in terms of possibility of small cell cancer in the patient. And this small cell cancer would be contributing to ectopic ACTH production. So the answer will turn out to be A. Otherwise, prevalence-wise, this is the data which is to be remembered. If he says what is the cause for development of Cushing syndrome, then the first reason for this would be exogenous steroids. After steroids, the next important cause would be pituitary microadenoma. And after pituitary microadenoma, the next cause to be considered by you is ectopic ACTH production. And if it is not ectopic ACTH production, then it could be an adrenal mass. It could be a autonomous adrenal adenoma as well. These iatrogenic, then is pituitary microadenoma, then is ectopic ACTH, and then is adrenal adenoma. I mean, these are the causes for Cushing syndrome that you need to remember prevalence wise. The data has been given in decreasing order of prevalence. सर वो बॉडी बिल्डर जो यूज करते हैं ना, वो बेसिकली मोस्ट ऑफ द टाइम टेस्टोस्टेरॉन यूज करते हैं, एनाबॉलिक स्टेरॉइड करते हैं. हम बात कर रहे हैं यहाँ डेक्सामेथासोन वगैरह की, है ना. वो बेसिकली क्या होता है, मिक्स हो जाता है. तो उन्हें पता स्टेरॉइड है तो डेक्सोना भी लेना शुरू कर दिया. अदरवाइज बॉडी बिल्डर में तो इट इज गोना बी मोस्ट ऑफ द टाइम टेस्टोस्टेरॉन दैट इज टू बी टेकन, बट वो डेक्सामेथासोन ले रहा है. द डेटा इज गिवन इन डिक्रीजिंग ऑर्डर ऑफ प्रेवलेंस. Ankit says if a non-smoker in this case, then the answer is pituitary microadenoma. Suppose, that's the point I'm trying to make, Ankit. Suppose in this question I remove all of this. ये second line पूरा second और third line हटा दो. Suppose in this MCQ Cushing syndrome in a 68-year-old male और उसमें ये सब बाकी सारा चीज़ें नहीं दिया हुआ है, then the answer would be given as a pituitary microadenoma. Why not D? Is it because of age? Yeah, doctor. Yes. In this particular question, because he is mentioned regarding hemoptysis, he is mentioned about a smoker. That is why, absolutely. Answer to 16 is alpha. We come to 17. This chap went on a trip and he is having diarrhea. He had multiple loose motions. He is having extreme prostration, fatigue. He is asking which is correct about this case. I am ruling out the mixed disorder, which would be easier to rule out. So any patient who's having diarrhea would be having is a normal anion gap metabolic acidosis. Yep, the answer would be option number D. So diarrhea is a cause of acute gastroenteritis, is a cause of NAGMA. No? The causes of HAGMA and NAGMA is what we have studied. Dr. Fuse is the mnemonic for it. That has been discussed multiple times. So I think this was a relatively easy question. Let's move to the next one. Yep, Dr. Fuse. 35-year-old banker is having, he was recently diagnosed with hypertension and he was started on AC inhibitors. He's having severe flank pain. I mean, kidney involvement with hypertension is always polycystic kidneys or CKD, either of the two. And we are seeing a large kidneys with multiple cysts. So I am assuming this would be ADPKD. And he's asking you the extrarenal manifestation in the patient, which would be liver cysts. And the question can also be asked as which of the following is unlikely to be seen in this patient, then it would be lung cysts. Sir, renal artery stenosis in this particular case would, I mean, if it was renal artery stenosis, then a person would not have flank pain, no? I mean, renal artery stenosis में तो flank pain नहीं होता ना, sir? Renal artery stenosis, even if it is unilateral, the only presentation would be that of hypertension in the patient. और उसने तो बोल ही दिया ना जब cyst बोल दिया यार, तो then the answer would be autosomal dominant polycystic kidney disease in the patient. Sir, वो मैं I think I've explained, no, that there is loss of corticomedullary differentiation. So you would be having cysts in both cortex and the medulla, and then these cysts will start bleeding. And because there is a bleed inside the cyst, so that will stretch the wall of the cyst and that will stretch the nerve endings, and that can contribute to the flank pain which is being experienced in this individual. The correct answer for this particular chap would be option number B, because that's a common extrarenal manifestation for these patients. Yeah, unlikely to be present in the lungs of the patient. MVP, yep, doctor, it's a mitral valve prolapse and a mitral regurgitation from the cardiovascular perspective. ACE inhibitors would be contraindicated in bilateral, doctor, not in a unilateral one. It's only in bilateral RAS. I mean, in bilateral RAS, we would not be using ACE inhibitors. Can you tell me the treatment for bilateral RAS? Patient is not responding to CCB and alpha blocker. Yes, Avinash. I have to give a mixed bag. I mean, I want everybody to be happy. What is the treatment for which is first to develop in this patient? Doctor, prevalence wise, it is liver cysts that are more common and usually the first one to be detected. Any relation with ACE inhibitor? No, doc. Unilateral is ACE inhibitor. My query to you guys is I have given a bilateral RAS patient. He's a bilateral RAS patient. I'm using amlodipine max dose. I'm using prazosin also max dose. And his somebody mentioned aldosterone antagonist. His potassium would be elevated, no? So you'll go for a patra, no? Percutaneous transluminal renal angioplasty would be useful. So for bilateral RAS, Avinash, you don't need to do a kidney transplantation, no? In a bilateral RAS, you need to control the hypertension. So you'll put in a stent. I mean, see, what I'm trying to explain to you is I have used all the conventional drugs. He's not responding to the conventional drugs. I've used max dose of CCP, maximum use of prazosin. The potassium of this patient was elevated, so I was not comfortable giving aldosterone antagonist to this patient. So the traditional management of the patient has been done. My question was medically refractory bilateral RAS, what would you do? Your answer is PTRA, patra, percutaneous transluminal renal angioplasty with stenting. We would not do a transplant, doctor. We will not do a transplantation for a vascular cause. Okay, 18 we are sorted. Doctor, 13, you are right. PR interval is prolonged in both hyper and hypo. The shortest explanation I can give for this is potassium affects both depolarization and repolarization of the heart. So if potassium is more or less, doesn't matter whether it is more or whether it is less, it will affect the flow of current from SN node to AV node. If potassium is more or whether it is less, gradient will change. The concept is gradient between inside and outside the cell will change, so that affects the flow of current. So I mean, I know that the first time when you read this fact that PR interval is prolonged in both hypo and hyper, the query is how, but I'm saying a simple logic, gradient. Don't get into more or less. I'm saying whether gradient is more, whether gradient is less, it affects the current and causes a PR prolongation in the patient. Okay, we sorted with the 18th. 19th is bread and butter because they always love to ask it. So I have to incorporate KF ring. I have to show you a KF ring anyway, and let's have the answers here. We have this chap. He's having dystonia, poor school grades, which tells you that there is a basal ganglia involvement in the patient. I mean, the movement I read regarding dystonia. And then there is a KF ring also visible in the chap, and he's saying, what are you gonna do in this patient for the initial investigation? So I am gonna do. Yes, guys, I am getting varied responses. Okay, I am getting a as an answer. भाई बहुत बार पढ़ाया मैंने. Serum ceruloplasmin is lesser even in primary biliary cirrhosis. Serum ceruloplasmin is lesser even in patients of nephrotic syndrome. तो nephrotic syndrome के patient में urine में ceruloplasmin is lost. तो क्या उसको Wilson disease हो जाता है? Sir, ceruloplasmin is only to be answered in case of genetic history is given. Suppose is MCQ में लिखा होता that the elder brother of this child or elder sister of this child has died due to some neurodegenerative disorder or due to liver failure. What test would you do? If there's a positive family history, ceruloplasmin works. Otherwise, ceruloplasmin values can be reduced even in cases of primary biliary cirrhosis and even nephrotic syndrome में pediatric cause दे रहा हूँ, kwashiorkor. भाई kwashiorkor में भी प्रोटीन बच्चा खाता नहीं है ना, उसको प्रोटीन खाने को नहीं मिलता, तो kwashiorkor के बच्चे में भी ceruloplasmin लेस हो जाता है, तो ceruloplasmin is not a reliable test. अब आंसर आ रहा है लिवर बायोप्सी. लिवर बायोप्सी इज नॉट अ इनिशियल इन्वेस्टिगेशन. सर किसी के मतलब पेरेंट्स को बोलोगे कि आपके बच्चे का हम नीडल डालेंगे, भाग जाएंगे, वो कहे नहीं नहीं कराना हमको. Sir, we need to do a screening test for the patient. The screening test for the patient is 24-hour urinary copper, which is always elevated, or suppose report normal भी आ जाए तो you can give a chelator to this patient, that is D-penicillamine. You can do a D-penicillamine challenge test and repeat the 24-hour urinary copper, because in these patients copper is not more in the blood. The copper in these patients is going to be more not in the blood. The copper is more in the tissues. So when you give D-penicillamine to these patients, and when you repeat the 24-hour urinary copper, it's going to be grossly elevated. When it comes to serum copper in patients of Wilson disease, it depends on at what time the sample was taken. Suppose a patient of Wilson disease is having a hemolytic episode, because copper is more inside the RBCs, and today when you did blood sample, hemolytic episode was going on in the body of the patient. If you do serum copper in the patient during a hemolytic episode, copper will be elevated, not reduced, elevated. But if you are gonna do this blood test, let me say 1 month after this hemolytic episode, because copper will be lost in the urine of the patient and will be deposited in the tissues, copper will be less. Serum copper is not a reliable test for diagnosis of a patient of Wilson, again, because it can either be elevated or can be lesser. If something can be either elevated or lesser, it can't be a diagnostic test. The reason for elevation is hemolytic episode. आपने test किया, you did a test after 15-20 days of a hemolytic episode, value can turn out to be lesser. Liver biopsy is a good test. In fact, nowadays if he says what is the best test for diagnosis of Wilson, your answer is I'll do a PCR. Sir, for any genetic disorder, you can do a PCR for, I mean, there's a defect on chromosome 13, ATP7B gene, so I can do genetic testing in the patient and be sure about a diagnosis. So yeah, we do a liver biopsy in the patient, agreed. But if I do a PCR for a genetic test, I've nailed the diagnosis. Serum copper is not reliable. Reason explained. Ceruloplasmin can be lesser in multiple other situations. So the correct answer for this one is option number C. Okay guys, why copper decreases? Okay, let me explain this. Very interesting question came up. I spoke a little faster. I wanted to see whether you will ask me this, and RY Tech picked up that question, though you have a tech name, but cool. Serum copper is lesser. There are two reasons. Reason number one, why copper becomes lesser in Wilson disease in future is because of copper deposition in the tissues. It gets deposited in the basal ganglia. It gets deposited let me say, apart from basal ganglia, there are multiple other sites. It's deposited in the cornea of the patient. So deposition in tissues is one of the reason. The second reason is urinary loss. Because of the combination of these two reasons, deposition in the tissues, please understand, copper is, Wilson is not a disease of more copper in the blood, it is more copper in the tissues. It's a defect of more copper in the tissues. It's not a disease of more copper in the blood. So the initial test or the screening test for this patient that we do is a 24-hour urinary copper. The answer to this question is option number C. Yes, Dr. Chakrabarti, you're right for Ming case. Yep, but then it would be a child, Dr. Doody. It would be a child, right? That kinky hair, mental retardation for a lesser copper. But you need to pick it up in the right perspective. Oh, great. Hi, nice to, okay, Robin, that's great. Let's move on to 20. We have this 40-year-old man who's having weight loss, recurrent episodes of colicky pain for last 1 year. He's shown multiple doctors for this recurrent tummy pain and weight loss. He's not getting an improvement. Your workup shows positive ASCA, CT abdomen shows multiple strictures, a diagnosis of Crohn's has been made, and he's himself telling you this is Crohn's disease, and he's saying what will be the initial treatment for this patient. Yeah, tremor with, yes, Avinash, we get a tremor and then we get speech defects. Tremor and speech defects are the two reasons why these patients would be presenting to you. Meet, as I explained, one thing is, KF ring and ceruloplasmin don't gel together. This is how he says, KF ring with neurological features has a 99% accuracy for Wilson, clinically speaking, and you confirm it with a 24-hour urinary copper. Okay, so for this chap, we need to give steroids to the patient. I'm getting A, B, multiple inputs. I'm getting a C also. Come on, guys, you can't mess it up. For Crohn's disease, we are supposed to give steroids to the patient. And because we're giving steroids to the patient, we'll be giving budesonide. The correct answer for this one is option number C. It has been explained multiple times in the routine videos as well. This could have been a one-liner question. And the question would have been, what drug is useful for management of Crohn's? If it was severe disease, then the answer would be infliximab. If it is severe, like suppose I say person is having severe Crohn's, and along with this the person is also having multiple perianal fistulas. He maybe underwent a surgery for a perianal fistula, but there is a recurrence of perianal fistula. When I say severe Crohn's and there's a recurrence of multiple perianal fistulas, then I need to use, for those patients, I need to use infliximab. Yes. No, sir, we have preparations available which can be delivered GI also. Yeah, topical, Dr. Kazi. I need topical actions, but I'll deliver it. The delivery will be via the oral route. It will act topically on the gut and will cause healing. Ankit says for refractory ulcerative colitis, we'll be going in for surgery. So steroids, then it is budesonide enema that can be given to the patient. And apart from budesonide enema, I can be giving prednisolone, and then I'll use biologicals for the patient like azathioprine, methotrexate, and infliximab. Okay. 21, they always ask a question like this with respect to alcoholic with confusion, repeated falls, and a gait ataxia. There is a sixth nerve palsy also present in the patient with nystagmus. So he's talking about alcoholic sixth nerve palsy. Mesalamine is also used in patients of Crohn's disease, doctor. Yep. But initial treatment would be budesonide. Okay. The presentation is that of Wernicke's encephalopathy. In this chap with Wernicke's encephalopathy, there is a sixth nerve palsy occurring. And he's saying, what would you do in this case? So you need to give thiamine and dextrose. And suppose I give B, then because I'm giving sugar first, it can cause worsening of the patient. So as far as alcohol is concerned, alcoholic hepatitis, delirium tremens, and Wernicke's are the common scenarios which are asked. If why answer is not B is, as I explained to you, the person can have a worsening of the features. So it's initially thiamine, then dextrose. Okay. Yes, Avinash, you're right. Moving to 22. Which of the following is not a complication of recurrent packed RBCs? Recurrent packed RBC transfusion. Yes, Avinash, I answered you. You were right. Otherwise, we can use mesalamine, no? Okay. Sixth nerve palsy, sir, that is a feature, no? Sixth nerve palsy is a feature that is seen with Wernicke's encephalopathy, no? You read, no? Global confusion, ophthalmoplegia. And when you read about ophthalmoplegia, the commonest nerve that is involved in the patient would be the sixth nerve, no? And he is having ataxia, so there is a recurrent falls in the patient. There is confusion, लिखा है ना यार, confusion and global confusion हो गया, और ataxia भी है, और ophthalmoplegia भी है. Okay. CT scan after a thiamine. Yeah, doctor. First, if I have a alcoholic and is having a Wernicke's profile, I'll give him ASAP thiamine and dextrose. And a CT would not give me any evidence per se, apart from picking up that okay, there could be lesion in the mammillary bodies, or there could be a a peri-dorsomedial thalamus that could be involved. Yes, Datta, you were right for what you said, that it can worsen the patient. Okay, great. Let's move on to the next one. Which of the following is not a complication of recurrent packed RBC transfusion? Sir, Korsakoff would not have any. It's a irreversible damage. No, once confabulations will occur, then there would be no. I would say, there would be no treatment available for the patient. Okay. The question says, which of the following is not a complication of recurrent packed RBC transfusion? So for people saying diarrhea, sir, we have graft versus host disease, no? So in graft versus host disease, there is a T cell mediated damage to the liver, and there is a T cell mediated damage to the GI tract also. So that can explain the jaundice and the diarrhea in the patient. So the answer cannot be C or D, as people are commenting, because when he's himself saying recurrent packed RBC transfusion, then with recurrent packed RBC transfusion, we usually have GVHD, graft versus host disease. So we are left between two options. One is gonna be acute lung injury, and second is TACO. One is transfusion related circulatory overload. Just use English to solve this question, man. If I'm talking about packed RBC transfusion, why do we use packed RBCs? To avoid the complication of volume overloading, no? So trolley can occur with anything. No trolley, it's not that trolley is seen only with fresh frozen plasma. Trolley can be seen with packed RBCs also, because WBCs can be present even in packed RBCs. WBC component can be present in packed RBCs also. Why do we give this, sir? The answer is not B. The correct answer is option number A, because TACO is something that is seen with blood transfusion. It is more common with blood transfusion and multiple blood transfusion. Here I'm saying recurrent packed RBC transfusion. Like for example, this is the case of thalassemia. Every month I'm giving 1 unit or 2 units of packed RBC to increase the hemoglobin of the patient from 7 gram to, let me say, 9 gram. So if I'm giving, let me say, 1 unit or 2 units of packed RBC to increase the hemoglobin, 1 unit causes about 1 gram hemoglobin rise, you would have in your hospitals given packed RBC to thalassemia patients. So TACO is something that will be more common with a massive blood transfusion, or per se a blood transfusion in a patient, and not with packed RBCs. The correct answer for this question would be option number alpha. The remaining, as I said, trolley can be seen with FFP, agreed, but then packed RBC के साथ में भी होता है. and GVHD will cause diarrhea and jaundice in the patient also. Okay, answer to 22 is sorted. We move to 23. हाँ सर, मतलब देखो, see, what I'm trying to do is a mixed bag here. Some of these are gonna be like damn easy, and some of them are gonna be like यार ये भी सही है, ये भी सही है. That's it. I said. I mean, don't bother about rare syndromes. Don't bother about rare चीजें, and don't try to कि मैं बहुत knowledge base बढ़ाऊंगा and I'll read lot of data. Just आप रोज रोज क्वेश्चन कर लो and practice कर लो, जैसे हम अभी कर रहे हैं ऐसे ही. Target आपको दे रहा हूँ, do 100 when you wake up in the morning. My request to you guys is do 100 questions in 100 minutes. Believe me, do it for next 10 days and you will yourself notice that your approach will change. हम क्या करते हैं, हफ्ते में एक बार देते हैं, and our main focus is कि यार mock में score कितना आ रहा है. Don't worry about that. Do custom modules से whatever you're reading on that day, notes etc. or whatever you read the previous day, उसके notes से related custom module से do 100 in 100 minutes and you will be sorted, I think. You have a patient of chronic hepatitis B who's non-compliant to medication. I mean, chronic hepatitis B, we could be using multiple drugs. Like I could have started this guy on tenofovir, or I could have started this guy on, I mean, there are multiple other drugs also available for hepatitis B. Let's not get into it. And now he's developed hepatic encephalopathy due to decompensated cirrhosis. So which of the following will be noticed? So all patients of hepatic encephalopathy will be having a very characteristic aphasia that is called as anomic aphasia. No guys, the correct answer, Raghav, I agree to what you are saying, but what I'm saying is, I mean, let me just go back to 22 because Raghav has a valid point. When do you give recurrent packed RBC transfusion? You usually give it for patients of thalassemia. I mean, that's one of the commonest indications. Thalassemia में blood नहीं देते ना सर, आप packed RBC देते हो. वो blood क्यों नहीं देते? क्योंकि टैको होता है, वॉल्यूम ओवरलोडिंग होता है. तो हम पैक्ड आरबीसी देते इसलिए ताकि हम मिनिमाइज कर पाए. तो क्वेश्चन है कि विच ऑफ दिस इज यूजुअली अनलाइकली टू बी फाउंड एज अ कॉम्प्लिकेशन. ओके जी, द करेक्ट आंसर फॉर द नेक्स्ट वन ऑफ हेपेटिक एन्सेफेलोपैथी सर, इसमें मैंने ऐसा एग्जांपल दिया हुआ है कि यू विल शो योर सेल फोन टू द पेशेंट. सेल फोन इज समथिंग दैट इन रूरल इंडिया से भी पेशेंट आएगा तो ही नोज कि ये फोन होता है. So when you show him something like a cell phone, he knows it's a cell phone, लेकिन he will not be able to explain it to you that this is a cell phone. So whenever you have hepatic encephalopathy, patient will be having difficulty in naming an object. For people who are saying A and B, those are features with respect to stroke. Motor aphasia is when Broca's area is damaged. Sensory is when Wernicke's area is damaged. Conduction aphasia is when the connection between the two is called as arcus fasciculus, which is damaged. In hepatic encephalopathy, ammonia will cause intoxication and will cause worsening of the performance of the brain of the patient, dominant as well as the non-dominant one. So you will notice that with dominant brain damage, difficulty naming an object, and then you will write numbers on the case file like this 1 2 3 4 5, and you will ask the patient to join them. I mean, assuming the patient is educated, he knows mathematical numbers in English 1 2 3 4 5, he can join them, and here you will notice he'll be joining them randomly like this, and you're saying कि भाई कर क्या रहा है? You told him 1 2 3 को serially join करो. So what I've also done before you is a number connection test or a trail making test. And in hepatic encephalopathy, because the parietal lobe, dominant and non-dominant, both are affected, so you will be getting two A's in the patient. That is the anomic aphasia and asterixis तो होता ही है, but the A's that I'm talking about is one anomic aphasia, and the second A that I'm talking about is apraxia. I said if a person is going into hepatic enceph, asterixis will anyway appear, but would be relatively late. Prior to that, you would be having is one anomic aphasia, which I explained to you. I'm just writing AN for that. And apart from this, you would also be having is apraxia, though the earliest manifestation in the patient would be psychiatric manifestations and alteration in sleep pattern. Triphasic waves will be seen when he goes into coma, Dr. Doody. Once he goes into coma, that is when you get triphasic waves in the patient, and that is when asterixis will disappear. That is when asterixis will disappear. Lactulose is given, yes doctor, to manage it. Conduction aphasia is when arcus fasciculus is affected. Yes, Dr. Chakrabarti, you're right for asterixis being negative myoclonus. Okay, fine. We are sorted with 23. Let's move to 24. Anion gap would be increased in all of the following except. Quick answers, guys. This should be a faster one. The mnemonic that we use for this is cult, so I think that can solve the problem for you. It's a all except question. Okay, Avinash, your question went up very fast. There was a lot of comments coming up. Okay, anion gap would be increased with ketoacidosis, uremia, lactic acidosis, and toxins. When it comes to a person having renal tubular acidosis, the patient would be having is, yes, Dr. Fuse again is what is to be used. So this Dr. Fuse, the R is coming up here basically. That would be a cause for NAGMA. The rest you can work up: ketoacidosis, uremia in a patient, and then toxins. The correct answer for 24 is option number A. And as usual, first aid USMLE book for, yes, it is sufficient, doctor. I mean, any book is gold standard, right? So any book is pretty good. Okay, right. So we are sorted with 24. The answer for 24 is alpha. Let's move to 25. We have the smoker with distress on climbing stairs. Okay, West Heaven classification यार थोड़ा सा उसमें चेंज हो जाएगा. Sir, ma'am, you need to remember the following aspects here, which are like this. That one, I mean, I would recommend you to read regarding anion gap topic, but I'm just giving you a quick overlap here. I mean, the common error, Hagma, the mnemonic is cult, and that is what most people fell in the trap that uremia renal failure से वो acute tubular necrosis को answer कर दिया. I mean, uremia can be written as acute tubular necrosis, acute kidney injury, CKD, any other terminologies. यहाँ पे जो डॉक्टर फ्यूज का निमोनिक है उसमें अल्फाबेट R will be for renal tubular acidosis. लर्निंग पॉइंट आपके लिए क्या है? लर्निंग पॉइंट है कि इफ देयर इज अ पैरेन्काइमल डिजीज ऑफ द किडनी और अ वैस्कुलर डिजीज ऑफ द किडनी लाइक रीनल आर्टरी स्टेनोसिस, renal parenchymal or vascular disease will cause a high anion gap metabolic acidosis. But if it is a tubular disease तो उसमें पोटेशियम सोडियम और नेगेटिव आयंस दोनों का इक्वल लॉस हो जाता है. If positive charges and negative charges are lost equally, the anion gap remains normal. So renal tubular acidosis is also a kidney involvement, but is not a parenchymal disorder and neither is a vascular disorder of the kidney. The concept is parenchymal disorder of the kidney, vascular disease of kidney, it's a hagma. In tubular disorder, positive and negative charges both would be affected. Ankit asks for low anion gap. Yes, guys, please comment in the chat box quickly. I want answers. Let's solve the MCQ for Ankit. When do you have is a low anion gap? Yes, guys, quickly. Yes, waiting for answers. Low anion gap. Bence-Jones protein wala condition, multiple myeloma. Low anion gap is encountered in nephrotic syndrome. anion gap का मेन वीडियो सुन लेना. I mean the anion gap टॉपिक जहाँ पे मैंने एक्सप्लेन किया हुआ है वहाँ पे I have explained low anion gap is seen with multiple myeloma and nephrotic syndrome. Paraproteinemias, absolutely correct. You are spot on, guys. You are spot on this. Great. तो इसको थोड़ा सा पढ़ लीजिए सर anion gap के टॉपिक को. At the moment, yep, cryoglobulinemia, agreed. Let's focus on 25th. Good evening, Dr. Ekta. We have the smoker with respiratory distress on climbing stairs. The AP diameter of the patient is more than the transverse diameter. That's the presentation of emphysema. And he says, what would you be doing in this patient? Okay. Yep. Very good. Insert a wide bore intercostal drainage tube in the 5th intercostal space in the mid-axillary line. ये कब करते हैं? टेंशन न्यूमोथोरैक्स में. सेकेंड इंटरकॉस्टल स्पेस में भी किस में डालते हैं? टेंशन न्यूमोथोरैक्स में. Our patient is not having tension pneumothorax. He's a simple case of emphysema. भैया स्मोकर हैज कम टू यू विद कंप्लेंट्स और रेस्पिरेटरी डिस्ट्रेस. स्मोकर को तो सांस फूलता ही है सीढ़ियां चढ़ने पे. जब वो सीढ़ियां चढ़ रहा है, ही सेइंग सर आई एम नॉट गेटिंग ब्रेथ. AP diameter is more than the transverse diameter, so he's having a barrel shaped chest. So the clinical diagnosis of this patient plus X-ray is also showing that. He has given you barrel chest plus he is also giving you a radiological finding of flattening of the diaphragm. If you get a flattening of the diaphragm and you get a barrel shaped chest and an emphysema in a patient, you need to give low flow oxygen to the patient because high flow देंगे तो फिर उसका जो drive है respiration का वही suppress हो जाएगा. We'll use a nasal cannula in the patient. Yes, tubular heart is also present here. Good observation. Doctor, I could not check your name because it just went up suddenly. But yeah, tubular heart is a good pickup by somebody. So for any patient having an emphysema, it's a low flow oxygen that would be used here. Let's look at the next question. Yes, Dr. Pratish Mehta. Drainage tube is inserted for a hydrothorax. Yes, it is put for a hydrothorax as well. If a person is having, let me say, a empyema, I'll put in a chest tube. And for tension pneumothorax, exactly, for removal of either air or blood or pus, we are going to do this. Okay. We are having a option B coming up now. Avinash says that post-operative patient, we are having a chap with distress, SpO2 is down to 80. Auscultation, air entry is reduced in the left inframammary or infraaxillary areas. In fact, very soon it might even become absent. And if I zoom in into the X-ray of this patient, you will notice that this particular area, there are no vascular markings present. So what this particular patient has developed at this particular time is, what this chap is developing at this point of time is spontaneous pneumothorax. He is not having tension pneumothorax because in tension pneumothorax, he should mention crashing of blood pressure. If you are saying perform a urgent needle thoracotomy in the triangle of safety in a patient, where do you do a urgent needle thoracotomy in a person? You do it for a case of tension pneumothorax. And how do you know it is tension pneumothorax? When you have a crashing patient. My patient is not crashing, his oxygen saturation is less, but there is no mention regarding unrecordable BP in the patient. And the remaining part of the lung of this patient will be compressed. So, if you have listened to the discussion pneumothorax in medicine and surgery, you would notice there are two terms described, tension and spontaneous. In spontaneous pneumothorax, हम क्या करते हैं? So in spontaneous pneumothorax, post-operative patient can develop pneumothorax. That could be maybe he was a former smoker, maybe he had lung damage due to COVID, or it could be a complication of mechanical ventilation which was done during anesthesia. आजकल तो कोविड की वजह से लंग डैमेज है लोगों को, उनका आपने मैकेनिकल वेंटिलेशन किया, उसको स्पॉन्टेनियस न्यूमोथोरैक्स हो गया. For management of spontaneous pneumothorax in a patient, you are not going to do a needle thoracotomy and you're not going to intubate the patient. You're not going to do a intubation. सी पढ़ो ना, वेंटिलेटर पे तो नहीं डालेंगे ना सर, वेंटिलेटर पे डाल देंगे तो न्यूमोथोरैक्स तो और वर्सन हो जाएगा. What are you gonna do in this chap? You're gonna give supplemental oxygen for this patient. Sir, don't comment, David, that's my point. Never comment on tracheal position and tracheal deviation in a case of pneumothorax, because emergency, we always do a AP view. And when we are gonna do a AP view in the patient, tracheal position cannot be commented. In spontaneous pneumothorax, yep, Avinash, agreed, but spontaneous pneumothorax, he could be a previous COVID patient who unfortunately after mechanical ventilation developed a spontaneous pneumothorax, or is a former smoker. So what are you going to do in this patient? You give supplemental oxygen. If it improves, it is okay. If this was a small pneumothorax, I will be doing a needle aspiration. I'll attach a 50 ml syringe with a needle, and under ultrasonographic guidance, I'll aspirate the air. But if the amount of air is more and the oxygen saturation is not picking up, I will insert a chest tube in the patient. The correct answer for this question is option number A. Please read up the pneumothorax patient and make the learning points for today. The BLS question, the ACLS question on pulseless electrical activity that I put up, and pneumothorax. These are like standard things which have been asked in your NEET PG in the previous years. So try to work it up. In tension pneumothorax, there would be history of trauma. Not exactly, doctor. Tension word tab bolna hai when there is a crashing of blood pressure in the patient. So there may not be trauma all the time. Mechanical ventilation can also cause a tension pneumothorax. Possibility of chest trauma is high, agreed, but then supplemental oxygen is the main treatment in this chap with a tube thoracostomy if required. No, doctor. Supplemental oxygen is to maintain the SpO2 of the patient. The main treatment for this guy is a chest tube. Most of the time, I think you have not, most of you have, I mean, maybe not focused on the aspects. I mean, whenever you read on about a multiple choice question on the topic of pneumothorax, we'll divide this into two, a tension and a spontaneous pneumothorax in a patient. For spontaneous pneumothorax, if less than 25% of the lung is involved, then you don't need to do anything. That would answer your question, Dr. Tech, supplemental oxygen. Robin, the question that you put up, if you're having less than 25% lung collapse, you just need supplemental oxygen. If it's 25 to 50%, then you need to add on and you put in a chest tube in the patient attached to underwater seal. But in a tension pneumothorax in a patient, the first thing that you do is put in a wide bore needle. This would be put either in the fifth intercostal space or in the second intercostal space. I mean, the lines will vary, triangle of safety versus the midclavicular line. And then subsequently, a chest tube would be deployed in the patient. So for pneumothorax, and one more thing, in patients of spontaneous pneumothorax, we might even be doing is a needle aspiration. And I've explained this, that this needle aspiration and wide bore needle is not the same concept. The wide bore needle part, in tension pneumothorax and needle aspiration, both would not be mentioning. Both would not be the same. If you ever have is an unrecordable BP, crashing patient, absent breath sounds, you first think in terms of tension pneumothorax in a patient. Dr. Ajit says, what do we do in X-ray showing a fibronodular fibrosis? Doctor, we'll try to find the cause and if we'll try to go in for a, if possible, a bronchoscopic biopsy or at least a CT guided biopsy to find which histopathological variety of interstitial lung disease is causing that fibrosis, because some varieties are steroid responsive. If we are having a non-steroid variety, non-steroid responsive variety, then we'll have to use drugs like pyrifenidone for management of the patient or nintedanib. How do we know that the percentage was less than 25%? No, doctor, here I'm not saying that I'm giving supplemental oxygen because it is percent. I never calculated on the basis of the X-ray. In this particular X-ray, all I decided was anybody having low SpO2, you have to give supplemental oxygen. Any patient who comes to you with a SpO2 of 80, you have to give oxygen to the patient. No, but I'll not give oxygen via positive pressure ventilation. That's my only point here. And the main treatment for this chap is because it's a large pneumothorax, so a tube thoracostomy would be required. Hyperinflation in an X-ray, doc, you would be able to see those. That's why I've given these two X-rays. No, I mean, if you compare vascular markings are absent in one of the segments. Let me just erase this dotted one and show you the raw version of it. I think permitting, or maybe if you can change the settings of resolution in your YouTube, because it tends to give it at the optimal resolution. If you go into the high resolution mode, you would be able to check out this I would say area where there are no vascular markings in a patient. And if I come to this particular X-ray, the one that is currently in the focus, the tubular heart, there is a flattening of the diaphragm in the patient and vascular markings are very much visible. Okay, so we are sorted with 25. 25 kind of a question would help you improve your rank, and then 27 is pretty straightforward. Common cause of transfusion associated hepatitis would be hepatitis B. Though the commonest route of spread of hepatitis B is sexual, but transfusion associated hepatitis would be hepatitis B. Okay, we'll do some easy ones now. MELD score is included, all of the following except. Let's have quick answers here. Post-operative atelectasis, doctor, would be a type 3 respiratory failure. Only basal lung segments would be involved, and most of the time the X-ray may not be able to pick up those, AP view may not be able to pick up the basal lung segments. So we'll have to make a clinical diagnosis on the same and use incentive spirometry for management of the patient. Okay, we will not be having a serum albumin in the MELD score. The components are bilirubin. Bilirubin INR is always a component. Creatinine is the extra one. And the reason why creatinine is present is because of the incidence of hepatorenal syndrome, which will occur in our patients. And any patient having a MELD score of more than 17, we have to register the patient for orthoptic liver transplantation. Serum albumin would be for child Paget score. Okay जी. Okay, you can use any mnemonic. I think इसके लिए तो mnemonic की जरूरत नहीं है. Then is fatty liver with the hepatomegaly would be encountered in which of the following situations? Yup. Yes, doctor. Yes, but if we go by conventional MELD or MELD NA, then we will not have serum albumin. Okay, let's look at fatty liver with the hepatomegaly, and yep, this would be metabolic syndrome. Kwashiorkor में होता है और उसके बाद में metabolic syndrome में fatty liver with the hepatomegaly would be present. बाकी इन दोनों में तो cirrhosis होना ही होना है. I mean, it would be cardiac cirrhosis in nutmeg liver. The answer would be B. Let's move on to the 30th one. We have this 20-year-old guy, flaccid paraplegia with ascending symmetrical paralysis and albuminocytological dissociation. So the case presentation given to you is of classical Guillain-Barré syndrome. There is evidence of demyelination on nerve conduction velocity. The ABG of this patient shows acidosis. I mean, pH is less and PCO2 is elevated. So there is a respiratory acidosis developing in the patient. Bicarbonate values are in the range of about 26, which is normal. So this is uncompensated respiratory acidosis, primarily because of diaphragmatic involvement in this chap. He's saying which of the following should not be done for management of this patient. Yep, we do not use steroids in GBS. We will use immunoglobulins, we will use plasmapheresis if required, we will ventilate because reason for ventilation will be respiratory acidosis in the patient. But there is no role of steroids because steroids are the ones which we'll be using for management of transverse myelitis. Yep. The answer to 30th is option number B. Okay, let's move on to the 31st one. A 20-year-old patient is having complaints of daily episodes of loose motions which are leading to disturbed academics. And there is a weight loss also with vitamin deficiencies. So we are dealing with malabsorption syndrome. And he's saying that which of the following will not be useful for this chap. Yes, guys. We do for carbohydrate malabsorption, we do a D-xylose absorption test. For carbohydrates, we also do breath hydrogen test. Fecal fat estimation is obviously for fats. But we will not be doing is a urine amino aciduria. Nahi guys, the question is saying which test is not useful for diagnosis. तो ये तो बताए हुए सर, breath hydrogen test is for carbohydrate malabsorption. D-xylose तो बहुत जगह पे होता नहीं है ना. I mean, D-xylose test would be mainly available in institutes only. So it is gonna be mainly breath hydrogen test that can be used. The correct answer for 31 is option number C. I'll rate that as a silly mistake अगर गलत हुआ तो मतलब that would not be I mean D would not be the answer. Okay जी. Transverse myelitis causes spastic paraplegia. Yup, doctor. Transverse myelitis will initially cause it will initially cause spinal shock. So initial first week when you will see transverse myelitis, you would be having flaccid paraplegia and sensory level root pains would be present. But when you examine the patient after 7 to 10 days, then in the legs spasticity would be occurring. That's the standard presentation. Spinal shock always evolves like that. Okay, confused with urease breath test. That's for H. pylori, no, doctor? It's not urease, doctor. It's a urea breath test. Maybe a typographical error there. Yep, the correct answer for 31 is option number C. Let's look at 32 quickly. Spastic is upper motor, no? When you're saying spastic, तो upper motor हो गया ना? यार वही है ना, लोअर मोटर अपर मोटर तो मिस नॉर्मर है ना. वो बोलता है बोलो कॉर्टिको स्पाइनल ट्रैक्ट. स्पाइनल कॉर्ड में भी तो कॉर्टिको स्पाइनल ट्रैक्ट होता है ना. तो स्पाइनल कॉर्ड में कॉर्टिको स्पाइनल ट्रैक्ट जहाँ पे कट जाएगा उसके नीचे जो होता है स्पास्टिसिटी आती है और उसके लेवल पे जहाँ पे कटता है वहां पे फ्लैसिडिटी आती है. एक्चुअली में अपर मोटर लोअर मोटर से लगता है ना ब्रेन में डैमेज है और नीचे डैमेज है, ऐसा नहीं है. वो बोलता है स्पाइनल कॉर्ड में भी तो कॉर्टिको स्पाइनल पाथ है, तो कहीं पे भी कट जाए तो उसके नीचे वाले में स्पास्टिसिटी और उसके लेवल पे फ्लैसिडिटी होती है. लीडिंग कॉज ऑफ पोस्ट ट्रांसप्लांटेशन लिम्फोमा. तो लिम्फोमा पूछा है यार, साइटोमेगैलोवायरस नहीं बोलना है सर. इट्स नॉट साइटोमेगैलोवायरस. आंसर इज एप्स्टेन बार वायरस. मैंने ग्राफ्ट फेलियर नहीं पूछा है सर. I mean couple of guys are making silly mistakes, तो अवॉइड कर लो यार इन सब चीज़ों को। मैंने ये नहीं बोला कि पेशेंट को पोस्ट किडनी ट्रांसप्लांटेशन ग्राफ्ट फेलियर हो रहा है, मैंने बोला लिम्फोमा, दैट वुड बी एप्स्टीन बार वायरस। अभी भी बी फीड में आ रहा है, इट इज आंसर इज ए गाइस, राइट, इट इज स्ट्रेट फॉरवर्ड। पोस्ट ट्रांसप्लांटेशन लिम्फोमा, पोस्ट ट्रांसप्लांटेशन ग्राफ्ट फेलियर नहीं। चलो ये थोड़े इजी हैं। विच ऑफ द फॉलोइंग इज नॉट एन ऑटोइम्यून डिसऑर्डर? या डॉक आफ्टर दिस आई विल हैव कॉफी ओनली, स्ट्रॉन्ग कॉफी। ओवर कॉन्फिडेंस में गलत हो गया, नहीं डॉक्टर अब नहीं करना है, अगली बार नहीं करोगे, अच्छा है यू हैव प्रैक्टिस्ड विद मी, सो आगे यू वुड नॉट रिपीट दैट। यप यप यप। Which of the following is not a autoimmune disorder? Well, answer is inflammatory bowel disease. It's an inflammatory disorder, but it is not a autoimmune disorder. So ये तो good. I think everybody got this correct. Moving to 34, flapping tremor. Flapping tremor would be called as asterixis. And asterixis would be occurring due to all of the following except. So ammonia rises, urea rises, carbon dioxide rises. All of them would contribute to development of flapping tremors. But when you look at option number D here, paralysis agitans, this would be a feature that you see with Parkinsonism. And Parkinson's disease would be having is presence of resting tremors. Yup, option number D here once again. Good. Okay, ji, we are sorted here. Yeah, negative myoclonus. Coming to 35, which condition would contribute to development of, yeah, resting tremor there. He says which of the following would contribute to development of hypokalemia, hypovolemia and diarrhea non-responsive to fasting. Very simple and straightforward one. When I say diarrhea non-responsive to fasting, I'm talking about secretory diarrhea. And if a chap is gonna be having secretory diarrhea, this would be usually a tea color stomach. I mean like tea, if you boil tea leaves, if you boil in water, so tea color stool would be present. That would be Werner Morrison. That would be watery diarrhea, hypokalemia is there, and acidosis can also occur in the patient. Answer to 35 would be option number B. Simmer's disease क्या होता है? तो it is pituitary damage. Like if person is having sickle cell anemia or hypertension, non-obstetric causes. If you're having non-obstetric causes or damage to the pituitary, then we call it Simmer's disease. Werner would be multiple endocrine neoplasia. Turcot would be related to inflammatory bowel disease and tumors, brain tumors. Werner Morrison, sir, read about neuroendocrine tumors and you will be able to solve it. Werner Morrison is alternative name for pancreatic cholera. Read the topic neuroendocrine tumors. Sir, we'll have to use somatostatin, no? Every time you have secretory diarrhea in a patient, you have to use octreotide. Karthik asked how to use, so we'll be using octreotide for the patient. Okay, 4 more to go today. For today, guys, we'll cap it at 40 for questions for today. This 45-year-old lady, no doctor, secretory and osmotic अलग-अलग है ना. Osmotic will respond to fasting ना. भाई खाना नहीं खाएगा तो उसको डायरिया स्टॉप हो गया, दैट इज ऑस्मोटिक. ऑस्मोटिक का एग्जांपल होता है जैसे कि सिस्टिक फाइब्रोसिस है, उसमें ऑस्मोटिक डायरिया होता है कि उसमें पैंक्रेटिक अमाइलेज नहीं होता. बट इन अ पर्सन हु इज हैविंग लेट मी से ट्यूमर ऑफ द पैंक्रियाज और न्यूरोएंडोक्राइन ट्यूमर्स, उसमें ऑस्मोटिक डायरिया होता है. हाँ जी. पेशेंट इज अनेबल टू ओपन हर आई, which nerve is likely to be involved? Okay, doctor. It's a big slide, but we just need to wind it off for at. Okay, fine. Let's just look at it. You can see that the eye is going outwards and laterally, so this tells you that the medial rectus of the patient is involved. So this would be okay. I knew that people will talk about 7th. So the point is when okay, patient is unable to open the eye, and you can notice that the eye is also looking laterally. So I don't think so that there should be any confusion regarding it, because 7th orbicularis oculi would be having difficulty in closure of the eyes. Yep. Down and out is ptosis. That would be a presentation with option number A. So yep, and plus that movement of the eye would not be present. Okay. Let's have a look at 37 here. Yep, third one. That's perfect. Which of the following is not a feature that is seen with Zollinger Ellison? Neuroendocrine tumor, another one. Little, I would say, tricky one, but still, let's try to solve it. I mean, you do have epigastric pain because there is an ulcer present, so that makes sense. Secretin study is the investigational choice for the patient. So two options is what I have. It's not a feature पूछा sir. तो epigastric pain तो होता ही है और secretin study is the investigational choice. तो A versus C में ही करना है हमारे को. Okay. Yes, yes, guys. सी गाइस, उसमें अगर गैस्ट्रिन ज्यादा बनेगा तो गैस्ट्रिन ज्यादा होगा तो अल्सर तो बन ही सकता है ना. वो जरूरी नहीं ना कि गैस्ट्रिन ड्यूडल ड्यूडल अल्सर करे. हो सकता है वो गैस्ट्रिक अल्सर भी बन सकता है पेशेंट में. जोलिंगर अलाइसन में जो डायरिया होता है वो क्लासिकली जो होता है वो उसका मैं रीजन बोलता हूँ. यू सी देयर इज मोर प्रोडक्शन ऑफ एसिड, सो दिस एसिड विल कॉज म्यूकोजल डैमेज, and when mucosal damage will be there, the surface area available for absorption will be lesser, and when surface area available for absorption is lesser, then sugar will be unabsorbed, and when sugar is unabsorbed it will draw in water. So that sugar which is unabsorbed and is drawing in water will mainly contribute to osmotic diarrhea in the patient. So yep, I mean, I understand the 31 37 will cause a bit of difficulty in answering between A versus C, but the logic to be used by you is either of the two. Either use the fact that gastrin will contribute to local damage and will contribute to a gastric ulcer, or because acid will cause mucosal surface, this is small intestine ka mucosal surface will be damaged, so sugar will be unabsorbed because everything in the gut is related to. Eyelids are supplied by seventh and third nerve also ना. उसका ये देखो ना सर, इसका आई मूव कर गया था ना laterally, तो that आई moving laterally outward है तो मतलब third nerve चला गया. That's the correct, I mean, a way to approach this. And the concept, coming back to this question, is small intestine is hampered and therefore osmotic diarrhea can occur in the patient. So A would be the more important answer for this one. Cytomegalovirus infection is common in transplants. Doctor, it depends on the time frames. If you go through the video, no, I've described within 1 to 6 months of surgery and after 6 months of surgery, the answer will vary. Site for ulcer, Pritish, would be mainly a duodenal ulcer because stomach में तो फिर भी protective mechanism होता है ना. तो yeah, I agree. That is what I'm saying ना. Between A versus C, here, I mean, most of the time in Zollinger Ellison you have is duodenal ulcers. Okay, answer to 37 is alpha. We move to 38. Carbohydrate related to blood grouping would be, yes guys, waiting for your inputs here quickly. Carbohydrate related to blood grouping. Yep, that would be fucose. Absolutely right. Yes, yes, multiple. It would not be small, Dr. MA. I would just like to correct you. It would not be small. It is multiple large duodenal. Definition of large duodenal ulcer is ulcer more than 2 centimeter. Gastrin इतना ज़्यादा है कि large duodenal ulcer normally बनता है H pylori के साथ में एक ही है ना. ओके गाइस, 38 इज डेल्टा. फ्यूकोज है, फ्यूकोज के साथ में गैलेक्टोसमीन अटैच हो जाता है, गैलेक्टोज अटैच हो जाता है, गैलेक्टोसमीन अटैच होता है, गैलेक्टोज अटैच होता है तो ब्लड ग्रुप्स चेंज हो जाते हैं. तो ब्लड ग्रुप की कॉम्पोजिशन आई एम नॉट गोइंग इनटू बिकॉज दैट इज फ्रॉम बायोकेमिस्ट्री, बट फ्यूकोज विद गैलेक्टोज वर्सेस फ्यूकोज वर्सेस गैलेक्टोसमीन विल डिसाइड ब्लड ग्रुप A and B. Okay, 39th is discriminant score, which I've already talked about. It is useful for evaluation of alcoholic hepatitis. There are two parameters which are to be used: serum bilirubin and INR in a patient, and we'll be using steroids for the management. Okay, these were a couple of, I would say, relatively easier ones. Which of the following is not a cause for phone की वजह से humming? Yep, maybe doc, maybe. Keep it away. Chalo, we're doing the last one for today, guys. At the moment, which of the following is not a cause of upper GI bleeding? So I do have more sessions, guys, and I'll I mean, take care of the remaining other topics as well. Okay, ji, which of the following is not a cause of upper GI bleeding? That would be option number A, that is mucus diverticulum. So today, guys, I have kept some easy questions in towards the end. Just wanted to sensitize you that in the exam it would be some very tricky ones and some that would be very easy ones, and you just need to not feel overconfident when you answer those PYQs and not feel underconfident when you get relatively new ones. So Dr. Roy, the new session date would come up very soon. I mean, for the PDF of this, if you're interested, you can either email me at marwamedicine@gmail.com, and in the telegram group also it would be available. Even in the PrepLadder telegram group it would be available. So I mean, I'll put it in the telegram group of PrepLadder as well, and you can procure the PDF from there as well. So keep the pressure on. As I always say, keep hammering and keep on doing questions on daily basis. I mean, though we spent little more time than my plan was to do 40 in 1 hour, but we spent more time than that. So we need to cut down on that and have faster reflexes going. Uh, Sir, on YouTube, Dr. Jitu Meena, there are multiple videos of mine that you can go through to practice multiple choice questions. Okay, guys, pro analysis, great job. Thank you so much. God bless you, and I'll see you once again. Take care, guys. Bye bye.